CGM manufacturers, please lower the cost. It has not only enhanced the reputation of your company, but also showcase your determination to drive health equality. Who knows, your share price will go up because of this. Research shows that CGM is the most effective tool for diabetes management. Later this afternoon, we have professionals from Hong Kong and from overseas talking about clinical and economic effectiveness and how other countries are providing CGM. We are honored to have Dr. David Lam joining our forum. Without further ado, may I have Mr. Dr. David Lam, please?
Thank you, Fina. And good afternoon, Professor Ma, Elaine, Joanna, and ladies and gentlemen. It's a pleasure to be here to share what I don't know with you. Because in this room, I'm probably the person who has the least experience of taking care of diabetic patients. Now, I'm a surgeon, so I do have to manage the pre-op and post-operative glycemic control of some of my patients. But that's about all, really. And if you belong to my vintage, you still remember that in the old days, we used the lancet, the metal piece of lancet, to do finger pricking a few times a day for our patients. And if they are in hospital for a few days, then all the fingers will be wounded. It's quite debilitating if they want to do some washings or writings with all those wounds on the fingers. So you can see that we have walked a long, long way from there. The first time I come in contact with the continuous glucose monitoring system is from a friend who developed type 1 diabetes in his 40s or 50s maybe. He likes eating very much, so he was very, very upset until one day we went out for a dinner and he feasted like everyone else. So he showed me his continuous glucose monitoring device. Now I'm not saying he's using it in the right way, but he said it gave him back his life because he eats as usual, and once his glucose shoots up, he gives himself a bit more insulin. I told him that's not a very healthy way of living, but still, that changes his life. Now, what I really want to talk about are three things. One is the accessibility for these devices, and two is the affordability, as Professor Ma and Vina has also mentioned. And the third one is about sustainability of our healthcare system, especially in terms of funding. Now, accessibility is something like, are we giving it to every single patient with type 1 diabetes? I think you know the answer much more than I do. But from a policy point of view, with a medical background myself, we would tend to think that, first of all, what is the clinical benefit? How much is that going to improve the glycemic control of our patients in the short term? How is that going to change the treatment regimen for our patients? And in the long term, how is that going to affect the long-term complications related to diabetes? So we look at these figures, and if it is useful, then by all means, we should go for it. And another aspect of this accessibility or question to ask is how much does it affect or improve the lifestyle of our patients? That is probably slightly secondary, but it's also important. The second thing is about affordability. I know I heard it just now, it's still quite costly for many families. There are a few things that can drive down the cost. One, when it is universally applicable, so everyone buys it, that drives down the cost. If there are competition, it drives down the cost. And I noticed that we have competition not only in Hong Kong, but also from across the border. I just Googled and I noticed there are some really much more economic brands across the border, which we can also buy through the internet. And another thing is about sustainability. Now, before that, another thing about accessibility or driving down the cost is whether there are competition from newer devices or newer technology. we know that non-invasive monitoring of vitals, including blood pressure, pulse, saturation of oxygen, and also blood sugar, is around the corner. How useful are they and how accurate these are takes time to prove. But when we say it takes time to prove in nowadays, it usually means just a few years, and then it'll be there. So again, how that is going to affect further our future management of diseases, including diabetes, is something we want to see. And that, again, could make a huge impact on the cost of what we are now driving to lower the cost for. So the third thing is about sustainability. Now, this is a big issue, especially when the government is having a deficit budget. The question is, okay, is this good? Who should be subsidized? Everyone? Now, you would realize that the government has just rolled out the public healthcare fee reform. It's not a fee hike. It's not only a fee hike. It's also a reform in that, apart from fee hike, another important aspect is a broadening of the waiver. So many people who are not eligible for a waiver today will become eligible for a full or partial waiver by the turn of the year. So, and that is important. So what they are driving at is really to make those people who can afford more to pay more, so as to channel the funds to those who really need it most. And I believe that is the right way to go forward. But again, of course, that's not very acceptable to many people who has been paying less for their service, although such as for our university professors, I believe you wouldn't feel too expensive if it costs you $400 to go see the A&E department. But still, people just don't like it. Why are you increasing the fee by a double, more than a double, when we could have used it for $180 a day each visit? But that is exactly what we are trying to drive at. Now, I understand we have friends here from Singapore, and I've just did a little reading, and there's a CHAS card where every single Singaporean citizen can apply online for a card, basically a subsidy card, and they come in different colors, and the person who applies for it knows exactly how much will he be subsidized for community medical and dental services. Who to subsidize and how much to subsidize, and what are the different levels, or how many levels should there be for subsidy, is always a big question. And in Hong Kong, our government has for many decades said it is not possible to do means tests for everyone. But that's for the past several decades. With technology today, I think things are very much different. And the problem is whether the data is accessible to the government for the health department compared to the tax department. The figures are all there. If it is not communicable, so the healthcare minister doesn't know how much am I paying on tax, so it will be difficult for him to decide how much should I be subsidized. But when someone, I believe, when someone really wants to apply for a certain subsidy, then he should consent for his tax and property information to be disclosed to the government. Otherwise, how am I supposed to do a means test? Now, the good thing about the Singaporean CHAS card is that it's based only on two things. One, the income. Two, the property rental value. In Hong Kong, I think we might have to be a bit more complex, such as other investment. We do not only invest on property, we invest in lots of other things. But then if we have investment and income put together, and for retirees, maybe on their savings, then I think it is easy, relatively, well, I wouldn't say easy, but possible to decide on the levels of subsidy for everyone. Now, when the government said they're going to broaden the subsidy, that means they have decided to do more means tests. But when we asked them, well, would you consider inviting our citizens to do the means test before they really have to attend the emergency department? The government tends to say, no, why don't they just apply when they have the need? Now, that's where I have some different opinions from our government. I think if our people can choose to apply for a certain subsidy level ahead of time, then that gives them the peace of mind. And if we decide we have, say, 4 levels or 5 levels of different subsidies, then we can easily decide which level of subsidy apply to, for instance, the continuous glucose monitoring device, the insulin pump, or some vaccines, or some breast cancer screening, whereas other people who belongs to a lower level of subsidy, they may be entitled to a certain degree of subsidy with co-payment. So that kind of level, setting different levels for subsidy and doing it ahead of time, I believe will be very useful and very helpful for our community. And that's something I'm still hoping to talk to the government. And in the long run, I understand that we hope that all children, at least children who has type 1 diabetes, will have enough subsidy for the devices. But here again, if we have that different levels of subsidies known to each family, that makes life very much easier and makes funding much more prudent. So we'll be staying here for maybe another hour or so, and I have to run. So I'll try and learn more from everyone here, especially the professors and colleagues and parents who have actually spent the time taking care of children who has type 1 diabetes. Thank you very much.
Thank you very much, the Honorable Dr. Lam. We met earlier, and I looked at him and I go, oh, he comes from the same school. And so because we have an old school tie, I will be very bold and say something. There was a very key word that's, for today, and that's called empowering progress. The real people here who are going to be empowering this are actually the patients, all right? They are the reason we are here. They are our key stakeholders. No child should be suffering because of diabetes. And if they have it, and when they have it, it's how do they live their lives with passion and with no limits because they have diabetes. Now, in my hand, I have something I hope you've switched off. It's a smartphone, right? Can I ask you, does anybody in this room have a very old Nokia or Ericsson? No branding problems, but those brick phones that we used to carry, or in the old days we used to call soichun. Does anybody have that and still use that? Can you just raise your hand if you own one of those and use that? It's in a museum. Okay, thank you. All right, so let's think of it this way. If you won't use a brick phone, and frankly, our government won't let us walk into a restaurant without QR coding ourselves. We can't go get a driver's license because we don't have an IM Smart app. We can't apply for entering a hospital sometimes if we don't have the pre-registration done. We can't book for something if we don't use our smartphone. Then the smartphone has become an indispensable part of our everyday lives. You can't even get a visa nowadays and enter a country without a smartphone. Try that in Singapore, it won't work. Now, what's my point? My point is technology has been able to help us. Our own government understands the need to use these new devices. You try opening a bank and using a bank without one. A little bit hard nowadays. Even KYC is done on a phone. We need to use technology to shine a light on the needs of our members. Our members are using this technology. Their lives have been incredibly impacted. And to show you the results of the survey we just did for all the members using CGM, I have a huge joy of introducing you to somebody whose entire life, adult life, has been not only raising her children, but being an absolute passionate advocate for the use of CGM to make lives better. This is not an easy task for anyone. She leads a lot of cutting-edge research on this, and she's a great advocate, and she's a friend to YDA. Please put your hands together for Dr. Lane Chow. Thank you.
Thank you, Manoj. I'm quite humbled to be in the presence of so many people, with lived experience of diabetes. And thank you so much, Dr. David Lam. Your very inspirational and insightful comments is precisely why we are here together today. And I probably, excuse me for my need for technical support. Okay. Oh, here we go. Okay, share. Good. So, so allow me for the next 20 minutes or so just to give everybody a quick summary overview about CGM and the current summary of the clinical evidence for CGM, and also importantly, the summary of the YDA pre-meeting survey results. So these are my disclosures. So just a little bit of a reminder. So what are continuous glucose monitors, or CGM? So basically, these usually are sensors which measure the glucose via an enzyme-based sensor just placed underneath the skin. So most of these devices are now quite small and can be placed on the arm or the abdomen. And they come with a transmitter which sort of transmits the glucose data wirelessly, sometimes via Bluetooth, to a mobile device, a handheld device. So the glucose you could see instantaneously on the screen, and also comes with info such as trendings, alarms, and also can now interface with a cloud so that carers and also healthcare professionals can also see the data. So what are the advantages of CGM? As Dr. Lam just mentioned, I mean, most of our people with type 1 diabetes still have to prick their fingers 4 to 6 times a day in order to accurately, dose the insulin correctly, and also avoid extreme surges of glucose. And this is, extremely painful and inconvenient. And also, the advantage of CGM is that you can monitor your glucose 24 hours throughout the day, even whilst you're sleeping. And it can help alert to the patient and also the carers in case there is a very low blood sugar level, especially nighttime hypoglycemia, which can be very, very dangerous, and people could be unconscious and be admitted. So I think nowadays, a lot of patients find very useful is the glucose predictive alarms. So for example, it can give you an indication of how rapidly the glucose is rising after a meal, or how quickly glucose is dropping. And this enables people to more precisely give their doses of insulin or other types of treatment. Now, finally, I think most importantly, it helps to reduce the burden of managing diabetes, which is something that people live with, every day, single day for the whole life. And it is some people will call it a lot of a mental stress and burden. And this CGM and other forms of technologies, such as insulin pumps, can really improve the quality of life via this way. So this is data from the Hong Kong Diabetes Pediatric Registry. So this was showing the usage of CGM in pediatric patients with type 1 diabetes in Hong Kong. So as you can see, this is, although this is data from a few years back, in places such as Germany, in the US, nearly up to a quarter of people would be using CGM. However, in 2018 in Hong Kong, only 10% of pediatric patients with type 1 diabetes were using CGM. Although I think this figure is improving, with many programs available, this is still, substantially lower than many other developed nations. So, what are the clinical benefits of CGM in type 1 diabetes? So, number one is that in randomized control trials and also in real-world data, use of CGM has been shown to reduce the HbA1c by 0.5 to 1%, and this can lead to a reduction in long-term diabetes complications. So for every 1% reduction in HbA1c, this reduces the chances of developing complications such as eye problems, kidney problems by about 30%. Use of CGM also reduces low blood sugar. So there is a 50% reduction in the number of hypoglycemic episodes. And in also real-world data, use of CGM leads to a significant reduction in diabetic ketoacidosis, or DKA, which is very serious, and people may be admitted to ICU for maybe up to a week. And also it reduces the severe hypoglycemia, leading to hospitalizations. It helps improve the mental well-being, reducing the hypoglycemia fear, anxiety, and also the quality of life. So this is just a study drawn from data from Australia. So in Australia, they introduced a universal subsidized CGM funding for people with type 1 diabetes aged below 21 years since 2017. So the CGM uptake increased from 5% to 79% after 2 years. And after they introduced the universal subsidy for CGM, they saw a twofold increase in the attainment of optimal HbA1c targets, that is less than 7%. And also importantly, they saw a significant decrease in the number of severe hypoglycemic episodes requiring hospitalization. So this was decreased by 50%. And in our ongoing real-world data collection together with YDA as part of the Jockey Club program, we are probably also collecting this data, and we're probably likely to see very similar trends. And we're talking about funding, and actually as part of this this study, they also did some cost-effective analysis, and they found that this universal subsidy was actually more cost-effective compared with a self-funded model. So, CGM is more or less, recommended for type 1 diabetes as part of a standard of care. So this is the American Diabetes Association guidelines. And you can see that it says that, real-time CGM should be offered for diabetes management in adults with, diabetes on MDI or on insulin pumps. And this is, class 1A evidence. And similarly, CGM should be offered to all youth with type 1 diabetes on injections or insulin pumps. So what about Hong Kong? Do we have any guidelines or framework? So I've drawn this from the Diabetes Care for Adults in Primary Care Settings, a framework document. So here it also says that CGM is important in assessing the effectiveness and safety of treatment in people with type 1 diabetes, especially for the prevention of hypoglycemia for people on multiple daily injections. And what about in people with type 2 diabetes? So currently, the evidence is more limited. However, CGM may also be beneficial in selected patients with type 2 diabetes who are on very intensive insulin regimens and who may suffer problems with hypoglycemia. So now I would very much like to share with you the pre-meeting survey that YDA and colleagues kindly conducted. And thank you very much to all people and parents and carers who helped to complete this survey. So this was sent out via YDA and also via our nurses and other healthcare professionals to a wide number of patients and their families. So in total, just a short space of time, this was only about a week or two, we collected responses from 526 people. Of them, 85% of people had type 1 diabetes, 10% had type 2 diabetes, and 5% had other forms of diabetes. 92% of them have used a CGM before, and approximately 80% were already continuous CGM users. So we saw we have a fairly wide age range. So we had young children as well as adults who were over the age of 40, and they also had a variety of different educational backgrounds. So one of the first questions we asked is, how did CGM impact their diabetes management and quality of life? And you could see that, over 80 or nearly 90% said that the CGM has positively or very positively, impacted the ability to manage their blood glucose levels. So for the benefits of CGM, the majority of people, nearly 84%, found it useful because they'd be able to see their real-time glucose readings. And also nearly 60 to 70% of them found the alerts for high or low levels very useful. And 70% also found that useful because it can lead to far fewer finger prick tests. As to the challenges with using CGM, the highest number of people marked the greatest concern are actually cost-related. This was nearly 78% of people marked this as the challenge, and followed by nearly 50% of them commented there could be skin irritation, and 42% occasional, they mentioned sensor accuracy issues. So we asked also the participants, if you were to not continue using the CGM, what would be the main reasons? And overwhelmingly, 94.7% said that it was mainly the cost which is of concern. Only about 26% remarked this is due to skin irritation. Now, there were a number of people who were not currently using CGM, and we asked them, what factors would make you consider CGM in the future? So 82% said that would consider it if it was subsidized by a government program, 71% if there were lower costs, and also some would consider it if there were maybe better insurance coverage or recommendations by healthcare providers. We also asked people, if what kinds of co-payment or subsidy would, make you or enable you to use a CGM continuously. So this is a very interesting question. So if we asked if the CGM was 100% subsidized, about 95% of people would be willing to use a CGM continuously. So if the co-payment was only 10%, then about 92% would be willing to use the CGM. And the figure is if the patient has to co-pay 25% with 75% subsidy, about 77% of people would still continue consider to use a CGM. If you go down to having to co-pay 75%, then only 30% of people said they would be willing to use the CGM. So what other funding alternatives or solutions would you like to explore or be open to accepting? I just collected a number of answers from nearly about 200, 300 responses. So a large number of people, gave the answer was, having hospital authority or government full subsidy. Some indicated they would consider an option would be a good bulk purchase discount or subsidized purchase. Some people stated they would be willing to consider partial subsidy. For example, subsidizing 50 to 70% of the cost of each CGM or self-pay below 300 Hong Kong dollars per month. A few also considered support from other NGOs. And I just highlight one comment from one of the respondents. 始終這是一項長年累月的需要視乎坊間願意資就基礎嘅要求同埋調適。So I think it depends on the willingness of the community to fund and the requirements of the organization. So we also collected a large number of other comments regarding the CGM and their concerns. So these are just some of the quotes I've extracted from the questionnaires. So this one says that 如果每日要額外支出2000至3000蚊在 CGM 上，經濟上會有一定嘅壓力。So having to spend 2,000-3,000 Hong Kong dollars on the CGM would impose a substantial amount of financial burden. 若停止資助對小朋友或產生長期負面嘅心理影響。So if the subsidies are going to end, it will have a very negative impact on the children, on their psychological well-being. 無法想像的困難，如果沒有 CGM， 就像失去了眼睛一樣。So if without the CGM, it's almost like going blind. So this is another quote. So the 2 years of CGM funding from the Jockey Club has been invaluable. CGM technology is not a luxury. It is critical for individuals using insulin to effectively managing their diabetes. To use an analogy, if insulin is the vehicle, CGM is the driver. And then finally, I think also a strong message to the government, 財政顧慮，希望政府可以納入為一型糖尿病嘅提供藥物醫療設備，讓一型糖尿病人可以改善血糖管理，同時減少政府長遠嘅醫療負擔。So if the government is able to support devices and equipment for type 1 diabetes so they can better self-manage the diabetes, this in the long run might actually reduce the expenditure for the government. So thank you very much for listening, and I will pass the stage on to Manoj to introduce our next speakers. Thank you.
we're extremely fortunate because we have two very prominent advocates and professionals who've helped bring CGM as part of their national health supply in their governments. So we have two, Professor Carr and Dr. Gardner, who'll be sharing their views, and they'll be doing this remotely. So I'd love to have Elaine introduce a bit more about them. And please do keep inside and write some questions because we'd love for you to ask them questions as well. Okay, thank you.
So, thank you. So could I see, is Professor Carr online? So as I say, we're extremely privileged to have Professor Peter Carr online with us today. So he is the type 1 diabetes technology lead in NHS England and also the co-author of the National Diabetes Getting It Right First Time report. So I think everybody working in UK and also in diabetes technology knows Professor Peter Carr because he's been instrumental in enabling CGM and also now automated insulin delivery systems access in the UK to make it nationwide. So maybe without further ado, could I welcome Professor Carr to our discussion? Thank you.
Thank you. Good morning. Good morning, everybody. Very kind introduction, and thank you very much for the invite to everybody concerned. Now, the first thing is technology. So just to make sure we got that right, am I sharing the slides? Shall I share the slide? Maybe easier for everybody else concerned. So bear with me 1 second. So I'm going to talk a little bit about where we have got to, a little bit of a story of a journey, also, and I think an important point because I've been listening to a lot of the speakers since the start, and time it takes and where we get to. So I'm going to start with this, and this is my philosophy of type 1 diabetes in my life as a clinician. So I'm a full-time clinician, do my clinics. This is the number, which I always say is what people with type 1 diabetes have in their lives as regards interaction with a clinician. That's all they have. According to most data, that's all they have. So 99.9899% of their time, people with type 1 diabetes are very much on their own, not necessarily with the support of any clinicians. And I'm not going to labor the point, as I'm sure you all know, but I really like this slide about what is it that's needed to drop HbA1c, which is what, from a policy point of view, and as mentioned, so I do a national policy role. It's about, my role is to make sure that we use the taxpayers' money or the money that's available sort of in a way that gives you the greatest return of investment. But I think it's very important for us in the policy to remember this thing about type 1 diabetes. So this is, which shows you what it is that takes you to drop HbA1c, not as an individual only, but as a population. And I think the important lines there is probably the last line, which is for the rest of your life. And I always say to everybody is that if you haven't done it, try checking your glucose 8 to 10 times a day. Just do it for a week, and then you'll understand the importance of why people stay away from it, because it's not pleasant. And I think that's quite important. So that's also comes in how many times you need to inject. And I think the importance, obviously, with type 1 diabetes is that, you know, all these other factors come into play. So what is the difference between, people ask, what is it that about blood glucose strips versus CGM? And I'll tell you very simply, I always give this example. Let's take the example of a world famous sports personality, which everybody knows, who everybody knows. Let's take Roger Federer. Everybody knows Roger Federer. If you came from space and you never heard of Roger Federer, and somebody showed you 4 pictures of Roger Federer, you'd have gone like, very nice looking gentleman holding a tennis racket. I have no idea apart from that. If I showed you some videos of Roger Federer, you'd go like, oh my God, look at that man. What a backhand, what a forehand, how elegant. And in short, in simple plain terms, that's pretty much the difference between being able to do 4 glucose, stabs a day, have a look at 4 random numbers, and having a CGM which gives you patterns, ideas, what's causing what, etc. You just have better understanding and visualization. So I think diabetes sits on, any chronic disease sits on these 3 things. And I think as governments, as policymakers, we are always focused on number 3. we need more access to trained professionals. And the problem in the world is that we don't have enough trained professionals. So you end up getting professionals who are not necessarily trained. But if you're living with the condition on your own for 99.9% of your time, and you give people better self-management tools along with peer support, things improve. That's not rocket science. So that's the fundamental of the philosophy that we moved into. So this was 2017, not a huge amount of years ago. We didn't have any Freestyle Libre in the country in those days. In pediatrics, our uptake was 4%. In adults, it was 0%. In pumps, it was there, 8%, etc. So there was no CGM in adults. And across the population, our uptake in continuous glucose monitors in 2017, when I started the role that I did, was about 1% across the country. So this was also a problem at that time. As things were going up, the problem was disparities opening up, whether based on deprivation or color of your skin. But where are we now? And this one is actually been updated since. This is data till about September or December 24-25. So as you can see, there's very few people who are now there without any access to technology. And that's taken us a long time. So our continuous glucose monitor penetration is in the high 90s. And at the most latest data set that we have from March 2025, our CGM uptake is roughly about 97%. Is it possible to do it? So this is how you tackle deprivation. And you'll hear a lot of debate about how do you tackle deprivation. I've always based myself on one fundamental thing. If you give it to everybody, if you work to give it to everybody, eventually everybody will get it. And that takes time. I think that's sort of one of the lessons that I always sort of share. This is what we've done with pregnancy as well, because that's a concept trial that women with type 1 diabetes who are pregnant, if you give them a CGM, you have outcomes improvement as regards fetal outcomes, admissions to intensive care units for babies, maternal outcomes. So we gave that all across the board without any differentiation in color. Then, of course, as mentioned, we have got the hybrid closed loops in play right now. And this is where we are. We gave out money. I'm not going to bore you with money, but I just wanted to share this probably one of the most important slides. This is every single type 1 diabetes in the whole of UK in kids to begin with. And the most recent data shows that we now have greater than 50% of all kids with an HbA1c less than 7.5%. And I'm going to pause and tell you very simply, at a population level, you will be able to, and there's a very, very good data set out there if anybody wants to have a look at it, and your country is in there as well. Every country can be looked at. And there's a concept which is called healthy year lives. What can you do and healthy year lives, how many years can you have without any complications if you have type 1 diabetes? And that differs from country to country, as you would expect. So for example, if you're in India right now, it's about 30, you lose about 38 years. 38 years, you don't have healthy year lives. So you have about 40, 44 years, at which point your complications set in. And I think it's important to realize that at a population level, you cannot drop your HbA1c at a population level below 7.5 without CGM. You can try as much as you want. You can get individual results, but at a population level, you just cannot. Every single international data will support you with that. With a mixed insulin, you'll get to about 8% or thereabouts. With the best basal bolus system and with glucose strips at a population level, you will get round about just below sub 8. But if you want to really go below 7.5, you have to go CGM. And if you want to go below 7 at a population, you need hybrid closed loops. And I think that's the decision point that everybody needs to decide about what are we trying to do to reduce complications. So that's a very important one. So that's been our trajectory, as you've seen, as we have gone. But that's CGM users across the board. As you can see, that there is no differentiation based on color, which is we are very proud of that. And there is no differentiation based on deprivation. So it takes a long time to get there. And I'm not going to pump users also going up, as you can see, pump and HCl, etc. But where are we now? Well, where are we now is CGM is now standard care for type 1 diabetes care. Insulin pump is now standard care for type 1 diabetes care for all children. So hybrid closed loop uptake, as of, I can tell you that data is going to come out next week because it's Diabetes Week in the UK. Our in the age group 0 to 18, our access to hybrid closed loop right now is about 67%. So that's 2/3 of all children are on it. Everybody's on a CGM. So what we're trying to do is shift the whole median of the country to below 7%. And the idea is that we try and give back as many healthy lives as possible. So just to give you a very quick and rough idea as to what that translates into in a UK setting, it basically means that any child or anybody who's got this will have up till 68 years of them living a life without any complications. That's what it translates into, in a population that roughly the death age is about 80. So what we are moving to a system is that with technology, take away complications. The other group that we are looking at as regards hybrid closed loops after CGM uptake has been high is women trying for pregnancy and women who are pregnant with type 1 diabetes. Same principles. And then we move into adults in different age groups, which is going to happen. We've got a 5-year plan to do that. So it's taken us about 4 to 5 years to get CGM access everywhere across the board. And we have worked with the international body called NICE, who do all the cost-effective work to tell us, is it cost-effective? And cost-effectiveness is an important bit as regards, is it worth investing the money? And we're very happy to share any number and data that any policymakers or governments would want. But I can absolutely tell you, as somebody who's been doing this role for nearly a decade in the world of type 1 diabetes and wider, you cannot change population numbers unless you introduce technology which improves self-management in people living with type 1 diabetes, full stop. You just cannot do it. You can try everything, and you can try whatever you want. Education, psychological support, they're all incredibly important. Access to trained professionals, everything is important, but you cannot beat the importance of self-management. Once you give self-management tools into play, overall HbA1c improves because your quality of life improves. And I think if your quality of life improves, the rest is quite straightforward going on to that. But there are challenges that we have. These are sort of scattered. So we have a synthesis from 2018-19, again, going back a little bit, whereby we looked at different specialist centers and we introduced training, because you can see there's a huge scatter plot, which basically means different hospitals have different uptakes of insulin pumps. So world of adults, that's also coming down as you would expect. So this has happened again because of CGM. You can see the impact of CGM in adults. The work that we have to do here is about tackling deprivation, which is our next step, which is what we are doing. But you can see the impact. I've shown you the impact in children. This is the impact in adults, and this is population shift across the board. So we've got some national funding in place, and we are giving out funding. So going back to the funding, so we look after funding. We have to lobby with politicians, sit down, explain, show them data. And I think for everybody, one of the biggest lessons I would leave is data is king. You've got to have data to sit down and justify what the changes you are basically bringing. So this year we've got funding of £60 million. We've got separate funding pots for disabling hypoglycemias and other issues, separate pot for pregnancy, because we want to target into areas where we can have the maximum benefit. But this has been the biggest factor of all, and those of you will know my work, and if you don't, you're very welcome to have a look at any social media channel that exists. The strength is in interacting with those living with type 1 diabetes and their parents and carers. And I think in a policy role, I don't have type 1 diabetes, but I think I find it a very unforgiving and unremitting condition. It's there at you all the time. And I think our role as policymakers is to try and make your life a bit better, is to intervene with interventions, which actually has got, which brings you healthier lives. I think that's very important. So, and for those of you in the room who are not type 1 diabetes, who don't have type 1 diabetes, apart from the quality of life debate about, do you want to, I think there's 2 or 3, there's one thing I always say is for a moment, if for a moment you close your eyes and think about the most loved one in your life, right? Whoever it is, your brother, your sister, mother, father, your husband, your wife, even your mother-in-law, depends on your love, whatever it is. And if you, by a stroke of magic, the type of magic you do not want, they have type 1 diabetes tomorrow, I think the question you need to ask yourself is that would you want them to have a continuous glucose monitor, or would you want them to prick their fingers 8 to 10 times a day? Because without pricking your fingers 6 to 10 times a day, you will not bring your control better. And if the answer in your head is absolutely, I would love them to have a CGM, then I think we should do everything to give it to anybody else. You know, if you're going to give your loved one something based on your view that it's a good technology, it will help them improve their quality of life, and I'm convinced about the data, then you have to do what you have to do. So it's taken us time to get there. I think that's one of the lessons that I've said, but we have got population improvements, and I haven't shown you the data. We have got pretty much everything you want in the tank. So we are now one of the most, from being one of the countries which have the lowest CGM and one of the worst outcomes in type 1 diabetes, we, as a country of a higher economy scale, which you all are as well, we now have some of the best outcomes in town. So our DK rates are down, hypos are down as a population, HbA1c is down, and healthy life years returned is up. So, which is what you want. So I think that's one of the sort of important bits that I would leave with everybody. And also to say that if you need any help from us, we are incredibly happy to share anything you need. You know, whatever paperwork you need, anything. I'm always happy. So one of the things that I do is, and I was asked by Dr. Ma to help, and I straight away said, yes, it's not a problem. Anytime, anywhere, anybody with type 1 diabetes globally, very happy to help out where possible. So I'm going to finish there and take questions, or I think after me is somebody even better and more important than me is Daphne Gardner, who you'll hear from. And she's amazing. So I'm not going to say any more, and but that's me done. So thank you very much for asking.
Thank you, Partha. Very inspirational presentation. We aspire to be able to achieve this level of equitable access in Hong Kong eventually. So perhaps without further ado, I'll introduce Dr. Daphne Gardner. Dr. Gardner is a senior consultant endocrinologist at Singapore General Hospital. She's also been extremely passionate in, lobbying for access to both CGM and pump technologies in Singapore. And we would love to hear her experience and sharing. So over to you, Daphne. Thank you.
Thank you very much, Elaine, Partha, and YDA for this invitation to come and share our Singapore experience in terms of incorporating technology for type 1 diabetes. These are the disclosures that I have for today. I'm part of advisory board and speakers bureau for these various companies. I do receive some research funding, as well as funding for regional preceptorships on insulin intensification. But just to sort of give everyone an understanding of the healthcare system in Singapore, in 2023, we have an estimated prevalence of diabetes of about 7.3%. And this is self-declared diabetes, so there's very likely to be more individuals with undiagnosed diabetes within this group. Our overall population is 6 million, of which 4 million are residents within Singapore, and of that, an estimated 420,000 individuals with diabetes, of which less than 5% of these have type 1 diabetes. But if you really break down the numbers, we feel that the prevalence of type 1 diabetes is actually even lower in Singapore. So we have 3 healthcare clusters. And I work within SingHealth, and you can see that within the SingHealth cluster, there are 8 primary care sites, 4 public tertiary hospitals, and 5 specialist sites dealing with various subspecialties. And when we looked at our SingHealth Diabetes Electronic Registry, we have 130,000 unique individuals with diabetes listed in the registry, of which only 1,200 individuals are listed as having type 1 diabetes, of which about half of these individuals are being seen within SGH. And between my team and I, we now have 2 endocrinologists and several nurse educators, advanced practice nurses, and dietitians who are all subspecializing in type 1 diabetes care. We see more than half of the individuals in SGH, so about 450 in a one-stop geographical setting. Now, when I first arrived back in Singapore in 2007, we really had very little type 1 diabetes self-management and education for our patients with type 1 diabetes. So as an example, one of the first few people with type 1 diabetes that I met, she was admitted for severe hypoglycemia simply because she had injected 8 units of quick-acting insulin for just roast duck. And so it just highlights the fact that because type 1 diabetes is so rare in this part of the world, it's so uncommon, that the needs of these individuals have been neglected for a long while. So we set about writing a work plan in order to bring the UK DAPHNE curriculum back to Singapore, and we've sent a team over to Australia to bring this curriculum back. And this is a 5-day group education course in self-management and advanced carb counting. And that allowed the team to then have the same language to educate, as well as to same sort of consistent managing to help people to self-manage their diabetes better. And that allowed us to onboard technology. We started out with the Medtronic iPro 2 retrospective CGM reporting, and then initiated the first pump. And initially, this was the Roche Spirit Combo pump back in 2014. And then in 2015, the Agency for Care Effectiveness in Singapore was set up. Now, this is an agency that was tasked to look at new technologies as well as therapeutics that were coming up, to look at the cost effectiveness of these various modalities of treatment, to then decide whether the governmental body should reimburse for these treatments. And so that was back in 2015. And so this is the 10th year anniversary. But in light of that, they called for a submission for health technologies appraisal back in 2016. And so that was their first call. And in 2017, I submitted an application for insulin pumps to be considered for reimbursement in type 1 diabetes. At the same time, flash glucose monitoring was launched in Singapore. It took 3 years before pumps were reimbursed, and that is for individuals with an A1C that was either above 8.5% or that had disabling hypoglycemia. And at that time, we had initiated 50 individuals on pumps, and with that approval of reimbursements, we were able to then increase our number of pump users. So with the pump reimbursements coming in, that allowed two things. One is that the pricing of pumps came down dramatically because with the reimbursements, the governmental bodies would then be negotiating with pump providers, the vendors, about decreasing their retail pricing or the pricing to the government. And in that way, they earn on volume rather than on per device pricing. And so that lowered the pricing, but that meant that if you're a subsidized patient in Singapore, you have access to the pump for 50% of the eventual price because the government pays 50% of the pump price. So currently, AHCL users are not reimbursed, and other types of CGM are not reimbursed. But in 2024, that same process of health technologies sort of reimbursement process also came through, and Dexcom G6 was approved for reimbursement. Now, this takes a slightly different reimbursement policy in that individuals are means tested as a standard. So that allowed the retail pricing of Dexcom G6 to come down from the 90 something dollars, Singapore dollars, to down to about $70. And then depending on your reimbursement status based on your means testing, you then will either pay between $20 at the minimum to $50 per sensor. So that actually dropped the pricing of the sensor by close to 50% in most individuals. And that also meant that a year on, we've had about close to 50% uptake of RT-CGM in Singapore General Hospital. Let's see. But so that is essentially our reimbursement policy. But I also want to take some time out to say that actually sort of engaging various stakeholders were important. So for example, this is a group that we helped sort of encourage to set up. This is the type1.sg, which is a peer support community. And together with them, we've organized events together with Medtronic as well as other industry providers to raise awareness on type 1 diabetes, to try and get them to be their own advocates, as well as increase the public awareness on type 1 diabetes. So if you can see to the left panel here, this is us engaging the Minister of Health in Singapore, and to make him aware that there was more than just type 2 diabetes, and to make him aware of the needs of type 1 diabetes individuals. Alongside part of this advocacy work, we also published a book with type1.sg, and this is published by Candy and Cheng Yong, who are both individuals living with type 1 diabetes, who interviewed families that have been affected by type 1 diabetes. And this book was written with the idea that we wanted to inform the next generation that were growing up what type 1 diabetes was about. So we actually distributed these books across the primary schools in Singapore and to the prison service. And we had students with type 1 diabetes going into the class and reading reading this book with their classmates, and it's provided in 2 languages. And alongside, we also held activities like this art workshop. You can see here, this block is built using 5 different cardboard blocks. And you can see a little CGM piece here. And within the same art workshop is a pair of twin sisters that were diagnosed with type 1 diabetes about 5 years apart, and they're both wearing their CGMs here. Alongside, we've also produced educational materials, and these are animation videos on the various practical aspects of insulin dosing in type 1 diabetes and how to self-manage. And the idea behind this is to provide people with tools to be able to use technology appropriately and to use it well. Next up, we'll be thinking about trying to speak to funders about reimbursing the advanced hybrid closed loop system. And with that in mind, we've worked with Medtronic on the cost effectiveness of using the MiniMed 780G advanced hybrid closed loop system compared to MDI plus ICGM users within Singapore perspective. And this is data that we took from the ADAP study, but also used our local data on individuals who initiated on the HCL system. And we did see a minus 1.5% fall in A1C from the initiation of the HCL system from MDI. But alongside that, we also applied one-way sensitivity analysis, and that was based on an A1C fall of just half, which is 0.8%. This data I'm showing here shows that essentially use of the MiniMed 780G was cost effective at an ISR of 33,000 Singapore dollars, which works out to USD 25,000. And with a reduced A1C of 0.8% rather than 1.5, we still felt that was cost effective. You will get an ISR of about 45,000 Singapore dollars. And we've submitted this to the funders as well, and we're still in communication with them, and we're hopeful that there will be a positive outcome, but it does require continued awareness communication to the funders. So if I were just to summarize from our experience in Singapore, that actually setting the stage was as important as building it up. So education in type 1 diabetes self-management and carb counting was essential in order for both people living with type 1 diabetes as well as our healthcare professionals to be able to speak the same language and to provide consistent messaging. And this also allowed us to have efficacious implementation of technology, because there's no point giving advice to someone and for them to be using it wrongly and not using it effectively. And then it's really building up the community in terms of awareness and advocacy work and evidence building along the way. So a lot of times the funders were asking for our local data. And so even upon implementation of CGM, we're now carrying out an audit, and then we'll be definitely returning that information to the funders as well, and then engaging the funders both in terms of the public platform level as well as on the ground level. And that's all I have today for you. I'll be happy to take any questions.
Yeah, thank you so much. So I'll pass over to Mano and see take any questions from the floor. I'm sure there are.
Thank you so much. Really insightful. Thank you so much for sharing your expertise and knowledge. I'm sure there are a lot of questions. I'd like to pass the mic to anybody who'd like to ask any question to both. Oh, there we go. Okay, we'll start. Here we go.
Thank you, Papa, and thank you, Daphne, for the wonderful sharing. You both highlighted a really important point, which is the central person around all this, of course, is the person living with diabetes. So how can we help to ensure that the voice, and we've heard about the survey on what our local population feels is needed. So what do you think we can do to help ensure that those voices are heard in terms of communicating this need?
Shall I go first from the Asian perspective? If Hong Kong population is very like Singapore population, very often people may be willing to speak up one-on-one to the healthcare provider, but it's very often difficult to get them to speak on a louder platform. And so what I found helpful is to gather them together as a group and try to develop a structure for them to then come together as a peer support community. We've also organized events to bring more people in. And then alongside the Adam book that we published, we turned it into a panel discussion. And that's when I invited the executive director of the Agency for Care Effectiveness to have a discussion around access. And on that same occasion, we also had a lot of interaction on the ground level between people living with type 1 diabetes with the executive director of ACE. And that really helped bring their voices closer to the funders to inform them what is needed. And along the way, we were fortunate in that ACE also started having patient engagement arm, in that they were looking at the therapeutics, they were looking at technology, but they also started thinking about the patient voices. And so that actually allowed them to develop that arm a lot more. And so now, even with the CGM piece, they were engaging them directly, putting out surveys to them directly. And also, I think the two-way communication process is so important as well. And so trying to find within that peer support community groups or individuals who are capable and will provide the right messaging to then also express their views back to the funders. I felt that all these various things seem to fall in line, but often they do need a push and they do need some degree of organization from perhaps people who have that experience or healthcare providers.
Yeah, I would probably add to exactly what sort of Daphne said, but I think one of the other things you could do is, as I always say, you know, as a healthcare professional, you're probably the only representative in most scenarios, unfortunately. So I think I always use a word to my fellow colleagues in different other specialties is that when you go into larger meetings, if you're the only representative, then you're always pushed to collaborate. And I think collaborate should not become collusion in the sense that you end up becoming, it's still both of them begin with C, but they are very different words. So in your drive to collaborate and compromise and all that sort of stuff, don't end up being the colluding factor that has now denied people with type 1 diabetes what they really need. To your question, apart from everything that Daphne has said, one of the other sort of things that work really well for us is sharing the stage. Because if you are asked to go on stage and talk to somewhere and you use your privilege or the time slot given to give somebody with type 1 diabetes even 2-3 minutes with you to stand up there and actually start the talk, it's incredibly powerful because you're sharing the stage together. So they all add up. And without repeating everything that Daphne has said, I think those are very important things. Peer support group, sharing stage, remembering that sometimes you are the only person in the room collaborating. And I think being very open and transparent to the community helps. Is if you go around and they see that you are genuinely battling for them, the community will bond behind you. So those are the things that I've learned, at least that's worked in our place.
問題啊，你其實可以用廣東話，俾個麥俾你問，咁我哋會幫你翻譯。你唔使怕醜，呢個係你嘅機會問好多問題。因為好緊要，因為英國佢哋同埋新加坡進步咁多咧，係你嘅聲音咧係好緊要而家。So is anybody 你想唔想問問題啊 ？Okay, perfect. Okay, 唔該晒。
Well, since we have Dr. Lam here, maybe we could ask David Lam, what does it take to convince you and your team to support us? Like seriously, I have diabetes. I've been a diabetic for 30 plus years. And CGM has been a game changer. Especially when I was carrying my baby, I used finger prick 10 times a day. And you know, this is really important for families.
Yeah, thanks for the question. To be a member of the Legislative Council means that we have to be advocates for the people and speak from the standpoint of a healthcare professional. Now, diabetes is a major health threat to the population. And with all the new devices and all the new monitoring system that is going to improve the long-term control and to reduce the complications, if the professors and the universities and all the guidelines say that is the way to go, then we have an obligation, a moral obligation, to push forward that kind of a service for the people of Hong Kong. The question is subsidy. As I mentioned earlier, the government, it's not practical to ask the government to subsidize everyone for everything, because you have children having diabetes here. I have elderly suffering from stroke there. And then we have also children suffering from a variety of diseases which makes them very much needy than other people. And besides healthcare and medicine, we also have other areas that we have to take care of. So how to make good use of the public fund is a major issue. So that is where we can all sit down and find out the best way to make good use of our public fund so that people who really cannot afford it, they will get the subsidy first. And people who are able to make use of their own funding, then they may have to pay a bit more. And there is also, well, I know Singapore is quite different from Hong Kong. Maybe people are more compliant with the policies of the government. But in Hong Kong, we noticed that it's not all the same. If you ask them to report their own, say, property assets and income, then it's not always the true answer that you want to look at. And then if you want to base on that to set different levels of subsidy, then you run into different troubles. And another issue about our people here in Hong Kong is that if you subsidize them everything, a full funding, a full subsidy, then many people will think that, oh, it's nothing, it's not worth going for it, so they just do not receive it. One example is the human papillomavirus vaccine. Back 5 years, 6 years, very expensive. Everyone wants the kids to have it, the daughter have it injected. And all of a sudden the government said, okay, we fund everyone, all for primary 5 and 6 children. And then everyone below, every lady below 18-year-old, every girl below 18-year-old will have full funding for HPV vaccine. And then what we are now facing is schools, parents do not bring their kids for vaccination because it is free. When it was not free, everyone wanted and asked for, why don't you subsidize? Okay, we subsidize you 100%. You don't want it. So there are lots of things that we have to think about based on the specificity of our population and to base our policies on that, rather than just to spend all the money to subsidize everyone with the good wish, the wishful thinking that because you fund them, they're going to use it. No, that is not true. You fund them, they're not going to use it.
Yeah. Dr. Lam, thanks for sharing your insights. But one thing is, you were mentioning about the consequence of people receiving all these subsidies. But one thing is how we can tap the doors of the authorities. We should make the first step. Say, like the girls, they ask how we can do that as YDA, all the patients. I mean, we have patients and parents, half of them are here right now. So what is the first step that we can approach? Say, for example, can you introduce us to see Dr. Low? Is it Dr. Low, the Health Bureau? Oh, yeah, it's Dr. Low. How can we approach them? How can we approach the office? I mean, we've done that 10 years ago, giving them a petition. But of course, we did not have receive a reply from them. I know this is a long journey, but we have to start doing it on the very first step. And then we have only about, all the type 1, there are about, just like Professor Ma mentioned, that we have only about 2,500 people to 4,000 type 1 people. That's not a lot of money. Say $20,000 a year, how much is that? But think of, if one of the patients got ketone or something, they have to send into the hospital for checking. It's $5,000 a day for the cost of putting them in a bed. So we have to think of the consequence, and we spend so much money bringing up our children, but they have the kidney failure, the heart disease. So we have to think ahead as authorities. I know we all know about the consequence, but what is the first step we can do? Can you please connect us with the authorities as a patient? And I'm sure the patients and the parents are every one of us want to do that. Let's do it in the very first step, like what Singapore is doing. I mean, we always compete with Singapore on everything, but they are doing it right now. And of course, NHS, Professor Carr has been doing it for 7 years. But we are so behind. Why? As I mentioned, that we are one of the richest cities in the world. But we are so behind with the technology, with the subsidies and everything. I know I mentioned to one of the parents that the tax rate we are paying right now is low compared with other countries. But we have to take one step, co-pay or 30% or 50%. We just can't close the door. I'm sorry I put you on the spot today, but please let us know, and I will keep knocking your door and annoy you every month. And what are we going to do? What shall we do? Parents, are you with me? Thank you.
I believe the first thing is data, and you have already collected lots of good data. And the second thing is to put it into the reference framework. I see that is already in the reference framework. Now, these two are very important steps, such that the Primary Health Care Commission is already aware of the changing trend of care for diabetes. Now then we're going to the third step is how to implement what is in the reference framework. Now that goes really to primary health care policies. And Hong Kong is very much nowadays, these days, into primary health care policies. We have done with the screening, pre-screening for diabetes and hypertension, also hyperlipidemia for adults. And there are several things on the list. It's really about prioritizing, and to enhance the treatment of diabetes is certainly one of the things we want to push forward for. Another thing would be the enhanced treatment of or enhanced rehabilitation for stroke patients. So we have a couple of things on the list, and it is important, as you mentioned, that to improve the overall treatment of diabetes is certainly one of those. Maybe we can work with the professors and the universities to send in some proposals to the government, and provided they are evidence-based, they are supported by universal guidelines, international guidelines, and they are already in local guidelines, then the next step should not be difficult. It's only about when this will be promoted and how is it going to be promulgated and what different types of subsidies would that be. So I believe we can work with the professor.
Thank you, Dr. Lam. We're going to ask Dr. Daphne, who's wanting to say something on this. Daphne, please.
Yes, thank you very much. I'm going to have to pop over to another meeting shortly. I just wanted to perhaps highlight that based on our audit for individuals who initiated the RT-CGM, we saw in our registry 0.7% fall in the A1C. And, this really is very consistent with all the various randomized controlled trials on the benefits of CGM in type 1 diabetes. And the other thing for funders to perhaps think about is that two things really. There is a finite number of individuals with type 1 diabetes. The budget is not going to be stretched beyond that towards the type 2 population for now, where it's a very, very specific subpopulation that you're looking at. And then the third thing is that even if you're going to subsidize it to the extent of co-payment, be it however much you put that ratio, 30, 50, 70%, not everyone is still going to pay for it, because for various reasons, it may be a personal choice of not having a device on them, maybe the alarms, even though it can be mostly switched off, or the data that comes out. And then some of them, even paying $20 means a lot to them. So you're not going to have 100% uptake. Certainly as healthcare providers, we want that kind of uptake, but at least you're enabling people who wish to improve upon their self-care and who wish to do more, that you've reduced the burden slightly for them. So that's all I had to say. Thank you very much for having me.
And Professor Carr, could you share your experience from the UK, since we were a former colony? We could probably learn from the UK, since many of us also got educated there. Please share with us what you went through.
I come from India. We were also a former colony. Don't you worry about that. I'll tell you one thing is that, and as I say, I have been doing a policy role for a decade, and you just cannot shift the dynamics of a country as regards type 1 diabetes without introducing the system. I can't make it anymore. You can try everything in the tank. Every single global data will tell you So leaving aside, not that you want to, because I think that's very important, any debate about quality of life, if you're in a policy space, and this is a conversation we're having all across the globe, whether it's Australia, and we have been working a lot with Australia, New Zealand, Middle East, all the countries, and it's a very fundamental thing. If you're in a policy role, and you are dedicated to, we want to reduce complications because we pay more in treating complications than prevention. This is prevention at its finest using technology. You will, and we are a country which does a lot of prevention work in type 2 diabetes. And we struggle to see the gains because of the impact that there is on environmental factors, deprivation, ability to have food, etc., etc. In type 1 diabetes, without CGM, you cannot bring the population levels HbA1c or turn the tide on DKA. You can try everything in the tank. Everything else will cost you more. And that's my fundamental message that I can leave. And as I said, we're happy to share any data you want from the UK on a population level to see what impact it's had. So, and the final thing I will say is the UK government is just about to do their spending review. So spending review, as you know, is very less based on emotion, as every funder will know and policymaker. We're about to get a major uplift in type 1 diabetes because of the data we have collected over the last 7 years, because of the population levels we have shown, and the extrapolation of reduction in complications. So I would categorically say is that, and I think the gentleman made absolutely the right point, because we are in meetings having the same discussion. What about the elderly, the strokes, and the child who needs cancer treatment and respiratory? But if you look at diabetes care, in type 2, a lot of focus, quite rightly, should be on young type 2 diabetes, because that's a huge, big problem going through, and you focus on them and you improve your return of investment. In type 1 diabetes, it is continuous glucose monitors. Without that tweak, your HbA1c levels will not come down below a level at a population level to reduce your complication rates or DKA rates. That's as straightforward as I can put it.
No other questions? This is a great time to ask. There we go. Yes, sure.
你好，林議員。咁其實我係一位呢個患者嘅嘅父親嚟嘅。咁我個仔咧咁用呢個 CGM 咧，其實咧我哋當佢呢個 CGM 咧係一種護身符嚟嘅，即係一個救命嘅設備嚟嘅。咁點解會咁講咧？呢個設備咧就係當佢喺呢個日間，如果係響呢個即係運動量好多嘅時候咧，咁佢夜晚嘅時候咧，我哋唔能夠篤手指，即係半夜起身篤手指啊。咁所以呢個設備咧係好有壓力咧。咁半夜嘅時候咧，我哋係好清楚佢低咗糖嘅。咁低糖嘅時候咧，我哋就好擔心會唔會出現併發症咁樣樣。呢個就係父母最擔心嘅事情嚟嘅。所以就算呢個馬會呢個資助2年之後咧完咗之後咧，咁我哋都要千方百計去使用呢件產品啊。咁當然我哋希望咧就係政府啦，能夠可以幫助到我哋啲患者嘅家屬咧，咁即係都幫助到啲患者啦。咁等佢哋啲小朋友咧能夠好即係成長嘅時候咧，咁少啲併發症。呢個係希望能夠政府能夠可以資助到我哋。至於資助幾多咧，咁點樣樣資助邊類嘅人咧？咁我覺得咧就係喺呢個一型嘅患者咧係第一要首先要資助嘅一部分，或者係另外咧就係2型嘅可能需要打胰島素嘅，咁呢部分人嘅就優先要處理嘅事情咯，係。
Okay, a little translation for this from this parent, a question to Dr. Lam, and he mentioned that the CGM is a lifesaver for him, the whole family, as well as his son. So what is the government can provide certain kind of subsidies to help them to continue? Dr. Lam. Thank you.
你嘅問題啦，實際上我都會好鼓勵你繼續係使用呢一類嘅監測儀器， 咁而實際上，我相信嚟緊都可能會仲有啲新啲嘅，甚至乎係無創嘅監測儀器。而無創嘅監測儀器，而家今天當然我哋未可以認證到佢嘅能力，但係即係都將來都會嚟緊。科技一日都會進步，我哋一日都係希望可以用最好嘅去照顧到我哋自己嘅病人，即係朋友啊、親戚，即係醫生、護士同家長，我相信都係喺呢方面係一致。咁而政府方面，佢喺基層醫療嘅發展嗰方面咧，你可以都幾放心。我睇到佢過去幾年嘅作為咧，都係積極嘅。咁只不過係財務佢嘅資助係能夠提供到幾多出嚟咧？我哋現在以一個低稅率，我哋係每年用喺公共醫療，如果淨係講醫管局係超過1000億，另外都有1000幾億咧係私營嗰方面。衛生署又有幾十，咁變咗一年係用咗2000幾億喺我哋嘅醫療上邊。咁你計翻，如果對比翻我哋嘅本地生產總值咧，都暫時嚟講低過好多其他地方。咁但係唔表示我哋有錢去再即係好似做翻以前一直以嚟過去所有去公立醫院睇病嘅個資助都係一樣，都係高資助。咁所以你見到最近嘅一個醫療收費嘅改革，公營醫療收費嘅改革個目標就係能者多付。咁可能將來新嘅措施推出嘅時候呢，個資助額都會係即係有需要嘅人士，佢係會得到多啲甚至全面嘅資助。咁我相信亦都係只有咁樣，我哋先至能夠延續到我哋嘅醫療上面嘅開支，即係而不至於話係爆煲。咁教育方面亦都係相當之重要啦。即係在座嘅應該對使用呢個連續性嘅血糖監測係有好好嘅經驗。咁但係我哋社會上面，你話如果而家得10% 嘅有需要嘅人係使用緊，即係顯示除咗你話係資助嘅一個概念之外，另外一個好重要嘅概念就係教育。教育我相信即係除咗話係醫生護士之外，家長自己去積極學習嗰個概念都係好重要。而大學佢有數據嘅時候，能夠係提供一種嘅數據俾政府作一個政策上面嘅做基礎，都係十分之重要。咁所以喺政策上、喺教育上、喺資助上幾方面咧，都係需要多管齊下。否則嚟講，我哋如果淨係單方面係睇住一個資助，我唔相信嗰個係可以達得到我哋預期嘅效果。
Thank you very much. Is there anything anybody would like to say? Yes, okay, one more.
Just one more question to Dr. Carr, because you are in UK. We said that there's complication if you have the complication in for the hospital, governments and all that, that would be a huge cost. Do you already have the data saying that paying how much teeny % to do the precaution versus the cost that in the future for the complications? What is the ratio we're talking about?
So just to give you an idea, so what we used to do is we used to spend off our budget, if there's, let's say, £100, we would spend £80 on complications and £20 on treatment. So that's now shifted across to £40 on treatment and £60 on complications. So that's the big shift that's happened. The idea is that we go to a point that instead of using £100, we can use, I don't know, £80. So thereby you have the efficiency, but it's definitely seen a shift across the board. And as I say, if you want to, please have a look at the Breakthrough T1D website. The global index that's been created is really useful because it will give you an idea where your country is. It's not accurate, it's not perfect because of data lag, but it will tell you what you will get by inputting CGM across a population, how many healthy live years you can get. And I think that's quite important, making the calculations for any funder and government. So it's worthwhile having a look at that particular bit.
Excellent. Thank you for that. And that number, those numbers are going to be very critical when there's going to be need to reach out to our representatives. We have a question from a young man here.
how did you actually calculate the numbers for the population? Some people would be using like CGMs and some people wouldn't. So how are those numbers actually calculated in the first place?
So basically, it's based on, first of all, the numbers that we look at is that if you look at all studies or if you look at any other country which has done CGM, what is the change in HbA1c you can actually achieve? If you're on CGM, not on CGM, on the CGM and a pump, or just on, so it starts actually from much lower down. It starts from what is the change you can bring if you are on, let's say, BD mix insulin, then you go to basal bolus for strips, then you go to basal bolus and CGM, and then you go to CGM and pumps. So that's the way the calculation is done. It's based on potential HbA1c drops that you see replicated into real life. So we will combine real world data and study data, and that will tell us what the drops would be.
Any more questions? One more, yes. This is great. We're having a lot of questions.
Hello, I would like to ask, how about we look at the vendors? How can we ensure the cost from the vendors gets down? Then government will have less money to pay, and then subsidy will be even easier. So how do we get the vendors and make it more competitive for them? And I mean, we need to look at this aspect as well. How do we?
Very important. And it's important to realize that all of us, countries that have done it, and as Daphne mentioned, will have deals with the companies at a local level, which they will not reveal at an international level because they don't want to have the same prices everywhere, which is understandable. So my encouragement would be, the first step would be, if government funders are convinced that this is the way to go, is that you sit down and you bring everybody around the table and you have that conversation, but it needs to be commercially confidential, which Dr. Lam and others will know, about sitting down and having that debate about what are the price changes you can bring which will help the government deliver this. And you're absolutely right. So we've done the same with hybrid closed loops in our country. We've got a national hybrid closed loop, or artificial pancreas, as people say. That's not been achieved just at giving people exactly what they want money-wise. You have to get them around the table and say, this is what we want to do as a government, and let's look at price. But it has to be commercially confidential for your country, so that the companies are not also penalized, because different countries are different sort of situation and status. So that would be my tip.
Any other questions on this for Professor Carr? Oh, yes, over there. Thank you.
係唔該，我想問下林議員嘅，即係因為頭先都提到咧，即係以我哋呢個群體嗰個比例數量可能係比較少啲，咁可能又未受到重視嘅程度會唔會低咗咧？咁樣咁相對如果頭先都提到啦，使嘅錢又如果群體比例多，咁使嘅錢咪多，咁樣申請多嘅錢又難啲咯喎，係咪？我哋群體比例少。申請嘅錢係咪相對又會少啲，比較容易啲咧？咁但係會唔會有個矛盾喺呢度嘅咧？我想問下。
多謝你呢個問題，呢個問法我都未諗過。因為即係譬如我哋考慮嘅就係一啲係超昂貴嘅治療，喺一啲極其罕見嘅疾病，即係最昂貴嘅藥物係差唔多千幾萬。一劑嘅藥，咁香港係用過兩劑至3劑啦。我哋唔會話因為係人數多少而係，我相信唔係我啦，我都冇話事權。即係政府唔會話因為人數多少而係去決定醫或者唔醫一個情況，而係睇個實質嘅需要。咁如果糖尿病喺香港絕對唔係一個少數，你話一型糖尿病嘅人數可能係相對少，少就係一個好事啦，即係我哋能夠比較上健康。咁但係長遠嚟講，你話點樣可以令到我哋用咗最好嘅科技去到減少一啲併發症發生？我相信呢個始終都係一個科學上嘅問題，絕對唔係一個藥廠推廣業務嘅問題，一個科學嘅問題。咁今天我哋見到頭先教授都講過，而家有好好嘅數據。咁有好嘅數據嘅時候，我哋點樣將呢個數據轉化為係一個平常用嘅指引呢？呢個就係個重要嘅問題。而好似頭先都講過咧，你見到我哋而家用嘅人少，咁價錢係一個問題。即係頭先我開始講，我講3樣，一個係可及性 （accessibility）， 其實可及性嘅時候，我冇講到一樣嘢咧，就有教育意義。即係如果在座嘅都用過，都知道係佢個好處。但係如果外邊仍然有啲朋友，包括大人嘅一型糖嘅朋友，佢係唔知道個好處，咁樣可能佢冇考慮過，咁變咗可及性就低咗。咁呢個係教育。第二樣就係個affordability， 即係佢係咪真係可以負擔得起嘅問題。咁其實所謂負擔得起有兩個概念喺處，第一係個價錢幾貴，第二樣嗰樣嘢不論佢貴平，佢到底係咪合乎我哋嘅需要，即係咪達到個標準。而今天嚟講，香港喺醫療器械方面咧係缺乏一個監管。我哋有一個自願監管嘅或者自願登記嘅體系，但係並冇一個法定監管嘅體系，未有啦法定監管體系。咁亦都係因為呢樣嘢，而政府亦都係已經成立咗一個籌備委員會。就係籌備乜嘢咧？籌備係將來會成立香港醫療同埋藥械嘅監管委員會、監管機構。咁到呢個機構成立嘅時候，當然我哋嘅藥物以至到我哋嘅醫療器械咧，佢都需要係通過佢嘅註冊先至能夠喺香港售賣。咁你話係咪要等好耐咧？亦都唔係，因為現在嚟講咧，即係我哋好多時都會跟海外嘅一啲監管啦，另外就係自己國內嘅監管。咁國內對於儀器同埋藥物都有佢成熟嘅監管體系。所以講到 affordability 嗰處，除咗係我哋而家香港常常買到嘅一啲牌子之外咧，其實如果真係有需要嘅時候，其他嘅牌子，包括國內自己製造嘅啲牌子係達到標準，係通過咗自己國家嗰個審批，會唔會都係一個考慮咧？佢哋會唔會都有一個引入競爭性，而係再將現在嘅價格係降低咧？呢個都係一個可以發生嘅事情都唔定。咁而第三樣今朝我都講過，頭先我都講過就係個 sustainability， 即係我哋能唔能夠係可持續。可持續就剛才都講過，即係到底個餅係咁大，我哋點樣去分？咁當然最重要就唔係睇人數，要睇實際上嗰個需要。而需要係頭先亦都教授講過，有冇實質嘅醫學證據資助？咁而家有。咁第二樣就係我哋自己負擔能俾到最需要資助嘅人先，咁呢個。咁至於你話幾時先至係會擺咗上去作為一個資助嘅產品咧？咁呢個就要同醫管局方面傾嘅，就係同政府傾就可以處理到嘅。咁如果當然將來嚟講，呢個儀器械都唔一定淨係喺專科門診，而係喺地區都可能會用嘅時候，即係基層醫療範疇咧。咁呢個我相信將來亦都係探討我哋基層醫療發展嘅時候，中一個要討論嘅一個空間。
Thank you so much, Dr. Lam. I have to say, first of all, thank you for being so open and sharing of your views. And of course, as a physician yourself, as a surgeon who spent many years struggling and sweating and studying to be doing what you do in the field of medicine. We all want to see a situation where there's no type 1 diabetes, there's nothing but healing. And with that, I will say thank you so much for all the energy you've given, your time today. And thank you for being a guide to us, because without your guidance and knowledge of how to navigate to help all those suffering from type 1 diabetes, young people suffering from it, how they can use technology to get healthier, stay healthier for the long term. And at the end of the day, it's an investment in our future, right? It's our investment in Hong Kong, because a healthy youth today are a thriving community for the future, which is our sustainable model as Hong Kong anyway. We are Asia's world's best city. I'm very proud to say that. And we need to stay that way. We need to stay ahead of the game. So thank you so much for everything you've done for us today and being here. We have a little souvenir from you from one of our stakeholders. Sophia, would you like to come up and present to Dr. Lam? Thank you. Thanks. And could we invite Fina and Joanna to join as well? Thanks. Dr. Elaine Chow and Professor Ronald, please. Thank you. Thank you so much. And thank you so much, Dr. Lam. Right, our next esteemed speaker. She heads the Diabetes and Vascular Medicine at the Baker Heart and Diabetes Institute in Melbourne, Australia. She is a clinical endocrinologist. For 30 years, she's been doing incredible research, particularly in the area of type 1 diabetes, and she sits on the board of various boards, councils, and policy groups to make in Australia. And she's actually the 2019 Australia award winner of the Australian Diabetes Society Kellyanne Award, thanks to all the work she's done in recognition of her contribution to clinical practice of diabetes in Australia. Would you please put your hands together for Professor Dr. Alicia Jenkins.
Well, thank you very much for the kind introduction and the opportunity to speak with you all. I'm really pleased to hear of the wonderful progress of the YDA Hong Kong Jockey Club CUHK partnership, with the progress that you're making with the continuous glucose monitoring. And I'd like to share with you some of the Australian experience that has led us to the current situation where the Australian government has now got CGM subsidised for all people with type 1 diabetes. But again, it's a long journey. Slides don't seem to be moving. So I'll just reshare the screen. So much for technology. Okay. These are my conflicts of interest. We've heard from several other speakers, such as Professor Elaine Chow and Professor Partha Kar, as to why we want CGM: to improve glucose management, reduce the risk of hypoglycemia, less hospital visits. And one of the things that we need to consider, apart from the less physical discomfort and a far better profile of glucose, is the reduced cost of finger pricking. In Australia, when we introduced CGM, the mean number of finger prick tests that a person with type 1 diabetes did dropped from an average of 4 a day to 1 every second day, which reduced the cost to them and, more importantly, to the government, who also subsidised the cost of that. As we've also heard, there's better pregnancy outcomes for the mother and baby if CGM is used, less risk of complications, and it can be cost saving for the healthcare providers, particularly because of the reduced hospitalisations and complications. There's a meta-analysis done by some Australian colleagues of a lot of international studies that show that, as Professor Carr has said, if the best thing to reduce hemoglobin A1C was improve glucose levels, is combining an insulin pump with a continuous glucose monitor. But of course, that takes 2 devices. But the data clearly shows that if you can only afford one system, then a CGM is the one to have. And this is something that our patients used to ask us. I can afford a CGM or I can afford a pump, but not both. Which should I have? And this type of analysis showed us that a CGM is the most useful. This map that we put, a student and I put together, shows the Western Pacific region, and it's focused on this map, which was with regard to where CGM is available. There's 6 different CGM devices available in the Western Pacific region currently. We have 3 of them in Australia, and competition is good for helping drive down the devices. But as you can see, the CGM is not available in all countries. It's getting more widespread, but it's not affordable in most, and few countries subsidise the technology. Australia, New Zealand, Japan, and then there's some partial subsidies in a few other countries. So for the majority, it's still a user pay scenario. Now, in our population of 27 million people in Australia, we have 135,000 people with type 1 diabetes, and that's good because it's a smaller number if you're asking people to subsidise helpful healthcare systems. Now, of people with type 1 diabetes, because most of them either they live long and well with their diabetes or they develop later in life, only about 11%, about 15,000 are under the age of 21, and about 15,000 are women of childbearing potential. So we started using CGM initially as Professor Gardner showed us as the masks CGM about 10 or 11 years ago, and then started using real-time continuous glucose monitoring in research, then in clinical research. And of course, technology is evolving rapidly. So initially there were 3-day sensors, and now we're up to sensors 14, 15 days. And initially for clinical use, it was the user pays, but since the middle of 2022, the Australian government has subsidised CGM for all Australians with type 1 diabetes of all age groups, with about 80% of uptake, with the groups that are tending to not use CGM as much are those people with type 1 diabetes over the age of 70. They can if they want to. They're usually supported by their healthcare providers, but that's their choice. So how do we get there? The government funds the National Diabetes Services Scheme, which provides syringes, continuous glucose monitoring, and insulin pump consumables, but not the insulin pumps, and more recently provides the CGM, or subsidises the CGM for people. So in Australia, people have the choice of 3 types, the Medtronic, Dexcom or Freestyle Libre, and they can change from one type to another and change back. All that requires is a form signed by their endocrinologist or their credentialed diabetes educator. So initially the government started providing fully subsidised access for people with type 1 diabetes under the age of 21 years in 2017. And then 12, 18 months later, they started providing it for women with type 1 diabetes who were pregnant, breastfeeding, or were seeking pregnancy. And they could be given CGM for 2 lots of 6 months. And then once pregnant, then they were given subsidised CGM for 12 months. Then in 2019, the next group of type 1 diabetes and concession card holders, so people who had disabilities, were military veterans or were pensioners, they all get completely free continuous glucose monitoring. Since the middle of 2022, all other Australians with type 1 diabetes get a co-payment, which is about 32 Australian dollars per month. So that equates to about 10% cost of the system. Otherwise, they were paying, depending on which system they had, about $4,000 to $5,000 a year. So a great outcome. And how we got there is by being persistent and having united front. People with diabetes are absolutely central, but this was achieved with partnerships with people with diabetes, diabetes associations such as YDA, healthcare professionals, communities, philanthropists who often provided, as the Hong Kong Jockey Club has done, access so that people could get experience to see how useful it was to them. Also industry dialogue, and of course with policymakers and government. So it took us years of persistent and united efforts that had the pillars of emotional aspects, clinical aspects, and economic cases. So as we heard before, data is key. So central to this, of course, are the people living with diabetes and their families. So there was lots of storytelling and testimonials, some in person, some images, personal storages, images from people with diabetes and their family, and particularly in highlighting what the benefit of CGM was. The healthcare professionals also provided the clinical data showcasing better glucose levels, less hospital admissions, less short-term and long-term complications. There was also a lot of public engagement with community meetings, social media, and online petitions to mobilise community support, such as the change.org one that I've just signed one for YDA, and community in forums, and there were even ads on TV. So this helped getting CGM subsidies to become not just a healthcare issue, but also a matter of social justice and equitable access to care. And in affluent countries such as you in Hong Kong and me in Australia and many others are fortunate to have, that I think is also important. So, and when we were involved with speaking with policymakers, we would often point out how Australia was lagging behind some other areas. The other aspects include direct lobbying to the policymakers. Again, not just with data, but also with those personal stories, and often having people with diabetes, children or young adults or older adults and their family members go along and present to the policymakers. But also with it came the hard clinical and financial data. Now, the economic framing that we used included what the immediate health benefits were of less risk of severe hypoglycemia, and in Australia an ambulance call out, for example, even without a hospital admission, was about 1,200 Australian dollars. Then there were the long-term advantages, in particular less costly complications. So one of the data that we presented to them, which is available in this PDF, which is available for free, is that CGM would cost the government about 14,000 Australian dollars per person over their lifetime, and would reduce the eye, kidney, nerve and cardiovascular complications by 18%, 21%, 9%, 2.5%. So significant reductions. And as we've heard from other speakers, these long-term complications are incredibly costly. What we did, we got the foot in the door first with children. So with type 1 diabetes, then with children first, then pregnant women, then pensioners, then others. So for the government, it was manageable numbers. So these were the sorts of images that we use. People with diabetes are absolutely key. We showed the data that this is Australian data, that across all ages, people who use technologies, be it CGM alone or with or without a pump, had better hemoglobin A1C levels. We also conducted a community-led survey by Diabetes Australia Victoria, which is an online survey with over 3,300 adults with type 1 diabetes. 81% of whom were using continuous glucose monitors. And 98% of them said that the devices were extremely important for them achieving better glucose control. 93% said it was extremely important to reduce hypos, and between 87 and 91% said it was incredibly important for their emotional well-being. This survey was completed just before the subsidy, and the biggest barrier was the affordability. So advocacy was also key. As part of the advocacy, this data is from when the children with type 1 diabetes in Australia had access to the free CGM. Before the subsidy, only 5% of people used CGM, but 2 years after, 79% of the youth with type 1 diabetes used CGM, and it more than doubled the number achieving the hemoglobin A1C less than 7%. It also showed that if people had used the continuous glucose monitoring more than 75% of the time, the hemoglobin A1C, shown here in green, fell and stayed down, whereas if they were episodic users, they didn't get as much benefit. And that's in keeping with earlier data. So continued using it most of the time is what's most beneficial. We also, again, more numbers, and this is a recent paper, post-subsidy, cross-sectional study of Australian people under the age of 21, showing that technology, including hemoglobin A1C, reduced hemoglobin A1C. Again, the combined pump and CGM was the most effective. But what was most important about this paper was that it showed, similar to Partha Carr's data, that people of all educational and socioeconomic status got that benefit from the technology. So that was important to show. We also, as was alluded to, model the cost effectiveness of using continuous glucose monitoring in two ways. And this paper's also been published previously. And we showed that based on what the cost of the technology was in Australia, the cost of the complications, the reduced cost of hospital admissions, etc., it was cost effective, not just if you provided CGM up to the age of 21, but if you provided it right across the lifespan. The government engagement led to an inquiry about the global state of diabetes in Australia, and a lot of that focused on the use of technology. And this came up with recommendations about not just continuing to subsidise CGM, but also to consider subsidising the pumps. In all of the advocacy that was done, it's important to be careful about the language that we use, and there are statements and some toolkits that are available, including some that are suitable for young people with diabetes to teach them how to be effective advocates. So in summary, again, I congratulate you on what you've achieved. I look forward to continuing to share anything that we've got, and also from learning from your journey, so that I can pass it on to help others. It's important to have multiple stakeholders and to use both an emotional, clinical and economic case, and also call for social justice. I suggest starting with support for children first is reasonable, and persist, and you will eventually get there. Thank you very much.
Thank you so much, Professor Jenkins. I'd like to, before we take any questions, I'd like to invite our next speaker, Dr. Juliana Liu, to come up and say a few words. Dr. Liu is a research expert here at Chinese University of Hong Kong in the medical department, and she did her postdoctorate at Oxford, and she will share her insights with us right now, and then we'll take questions after that. Thank you.
Thanks for staying here till afternoon and the weekend. So I hope I won't bore you with a lot of math and equations, because when we talk about, health economics here, it's another language. I try to make it really easy in 2 slides. It's a language to communicate with policymakers. So how to communicate the data and outcomes to the policymakers. So thank you. So what is cost effectiveness analysis? We always hear about it. I always show this slide. It's actually comparison between 2 interventions. Normally, it's a new intervention such as CGM compared to an alternative intervention, which is normally a standard of care, for example, SMBG or intermittent CGM, which I'll talk about a bit later. And then, so there's always this ratio that we always talk about, you know, those social return of investments, like all economics is ratios. So this ratio is called incremental cost effectiveness ratio. It compares the cost of intervention A minus intervention B over the effect of intervention A to the standard of care. So for costs, we look at direct medical costs such as medication in patients, and indirect medical costs, we look at productivity loss and caregiving costs. And for outcomes, we look at not only life years lost. So life years lost mean when patients die or we extend their life, right? We also look at quality adjusted life years. Okay, quality adjusted life years. So for someone with diabetes with a stroke or without a stroke, of course, someone with a stroke would be having a worse quality of life. We also take that into account, that they improve their life quality adjusted life years. So apologies, this is like the last slide with these technical terms. So this is a cost effectiveness plane. It's basically a 4-quadrant, and then with the ICER, for the y-axis, this is the cost difference. So when you're more up in the y-axis, that means the cost difference is larger. When it's lower, the cost difference is negative. And then on the x-axis, the effect is larger, so it improves the life years and quality adjusted life years. If it's in the left-hand side, then the effect of the new intervention is worse than the comparator. And then there's this green line, which is very important. It's called the cost effectiveness threshold. That's the threshold that each different policy region use to define if they adopt this intervention. So for cost effectiveness thresholds, UK NICE has been using 20,000 to 30,000 pounds per QALY. For USA, they don't really use this threshold, but it's in the literature. It's 50,000 to 100,000 US dollars per QALY. Hong Kong is still using the World Health Organization threshold, which is normally they use for the third world countries. So it's a 1 to 3 times GDP per capita. Apparently, Hong Kong is not that developed in health economics analysis, but we are moving forward, hopefully. So the big question. So are CGMs cost effective in patients with type 1 or type 2 diabetes? Here's a systematic review done by a very active health economist, Talitha Feenstra's team. She's also in the Mount Hood Diabetes Network. Mount Hood Diabetes Network is some sort of very conference that we gather with all the diabetes health economics model experts. She did this very wonderful systematic review of all the regions with CGM cost effectiveness study for type 1 diabetes. I generated the slide. It's basically summarizing all the 34 studies that she analyzed. And you can see in the map and also on this bar chart that most of the studies are done in the Western population, with Sweden, Canada, and Australia champing. And then in China, there's only 1. So obviously, out of all the 34 studies, there's only 1 done in an Asian country. So I guess we need to pick up on this area. And this is a summary of the cost effectiveness plane. On the left-hand side, if you still remember, we have this 4-quadrant. So this is in the quadrant on the upper right-hand side, yes. So you can see those 2 lines. One is the 50,000 US dollars willingness to pay threshold to 100,000 USD threshold. So anything below that line, the orange line or the blue line, whatever that, that region is adopting, those studies are cost effective. You may ask why there is so many dots, because there's only 34 studies, but sometimes we do different comparative arms. So for example, we may compare it to SMBG, we may compare it to ISCGM. So one study may have multiple outcomes. But in general, you can see that most of the studies are cost effective for type 1. And then on the right-hand side, this is actually showing that for the comparators for the studies, for RT-CGM, no matter for HCl, hybrid closed loops, or the SAP, or multiple insulin injections, most of the comparators is self-monitoring blood glucose. That's the blue part there. And then some of them may compare it to ISCGM. But yep, so that's a summary of that. So let's look at the, can we get this away? Let me see. Okay, I can do it. Okay. 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 So this is two studies from UK. One is on type 1, one is on type 2. So in the UK, they adopt the willingness to pay threshold of 20 to 30,000 pounds per quality. And you can see in the boxes red, these ICEs, the incremental cost effectiveness ratios, is nowhere near to that 20,000. So this is very, very cost effective, very below their thresholds. No matter if it's a whole overall type 1 diabetes cohort or in a baseline with HbA1c of 8.5% or more. It's only around 9,000, so it's way below the threshold. What about for type 2 CGM, type 2 diabetes? For real-time CGM, the ICE is only 3,600. So I think it's quite cost effectiveness here. Oh, I need to specify. So the type 2 diabetes in this population is on insulin therapy. I missed that in the title. And then let's look at the United States cost effectiveness for type 1D and type 2D. So there's two studies. So the threshold they use in the US is mostly 100,000 US dollars per quality. They don't use it in the policy making, but mostly in the literature we use that. So you can see that it's around 98,000 per quality for the type 1 diabetes. That's below the willingness to pay threshold. And then the quality adjusted life years, you can see that there's slight improvement. I need to explain what is a quality adjusted life year. So it's basically rating your health from 0 to 1. So 0, it's worse, like death. 1, it's perfect health. So improving around 0.54 qualities is quite good, because for Hong Kong, I calculated that for having a heart failure, the quality of life decrement would be around 0.6 decrease. So that's saving like a heart failure. That's kind of trying to convert what this number is. And then for type 2 diabetes, this study, it actually shows that it's dominant. It's called cost saving or dominant, whatever. So that means that it's saving your money and also improving your quality of life. So it's over a 10-year horizon. 10,000 US dollars increase in glucose monitoring costs would offset by 12,000 reduction in the treatment cost. So you're actually saving money in using this. But sometimes this really depends on what model that you use and what your assumptions are and what your regional context is. So most of the cost savings were reflected based on the avoidance of severe hypoglycemia, diabetic DKA, and then also incidence of renal failure, which I found that from all the summaries that I got, renal failure is the most expensive and the most cost saving from using CGM. And then MI and congestive heart failure of 1,000. Okay. So, and then let's look at Canada. So Canada, the willingness to pay threshold they're using is 50,000 Canadian dollars. And you can see that in this study, they modeled using the Diamond trial patients with type 1 diabetes with multiple injections. And the ISA is 33,000, the ratio. So that's also below the Canadian willingness to pay threshold. And you can see that the quality's improved, it's quite high, and life saved, and also it's more cost than using SMBG, but it's still below the willingness to pay threshold. And then let's look at a multi-center RCT done by Albert. Albert is in University of Chicago, which I will see him in 2 weeks' time. So this is a multi-center trial, and it also looks at HbA1c above 7 or below 7% in type 1 diabetes. And you can also see there's an increase improvement in QALYs if you use a CGM. And also the ICEs, it's around 78,000 to 98,000. That's also below the 100,000 willingness to pay threshold. So this is also cost effective in a multi-center RCT. Though this RCT is mainly white Caucasians, actually, 100%. So let's look at Spain. So Spain, okay. So Spain, the willingness to pay threshold is 30,000 euros per QALY. And you can see that the base case ISA for type 2 diabetes on insulin, it's only 2,500 euros per QALY. That's way, way, way below the willingness to pay threshold. And then I screen capped this table. It actually shows you the savings from different treatment and management, and also the complication costs in hospitalizations. So as I mentioned, the first most saved cost is from renal complications, followed by ulcer, neuropathy complications, and then adverse events including DKA. I see this trend actually across multiple studies. So let's look at in France. France, the total mean lifetime cost was saved around, so there's only an increase in around 11,000 euros. With an increase of 0.47 QALYs, and also the ICER ratio is 23,000 euros, which is also below the willingness to pay to threshold, which is 147,000, which is way, way, way below the threshold again. And you can see that, as I mentioned, the most expensive would be renal complications. You would be saving the most cost from renal complications. I think this is from a trial data. So you can see that after using RT-CGM, there's no cost in severe hypoglycemia and DKA. So these are the second and the third most saving in the cost in complications after using a CGM. And then let's look at South Korea, somewhere near Asia. So they have an ICER for the type 2 diabetes with intensive insulin. In the study, the ICER is around 24 million Korean won, which is way below the accepted willingness to pay threshold of 46 million per QALY. And there's also an increase in QALY over the 10-year horizon. So basically, from everything that I was talking about, CGM is cost effective. It's been improving quality adjusted life years. You can see in this column, you don't see any negative sign here. Although sometimes it may incur higher management and higher management cost, but it is always way below the willingness to pay threshold that regions adopt. That's when that's the threshold that they decide whether they adopt this technology. So I would say that in most countries, this is cost effective. So here's a summary of reimbursement situations in Western population. So in the United States, the funding model is through government or healthcare insurance. The payer is Medicare, Medicaid, or commercial insurance plans. So in the coverage and reimbursement, the reimbursement for type 1 diabetes and insulin requiring or a history of hypoglycemia for type 2 diabetes. And the Medicare actually fully covers the CGMs under durable medical equipment benefit, while the Medicaid coverage varies by state. So Medicaid is actually for less privileged people, and then Medicare is for 65 or older US people. And the reimbursement copay actually depends by insurance plan if you're going by insurance plans. For the UK, we've listened previously, all the type 1 diabetes are eligible for IS-CGM or RT-CGM regardless of age. I copied this from the NICE guidelines. And then the type 2 diabetes are eligible if they are on multiple daily injections, frequent severe hypoglycemia, or by the decision by the healthcare professional. And then for Canada, it's paid by the federal or the provincial. It varies across different regions, but in general, it's kind of reimbursable. There's also a tax payment credit for people using CGM in type 1 diabetes. And then for Australia, we've also heard about it from Professor Jenkins. I got this from their NDSS website, which I won't repeat. But basically, that's type 1 diabetes below 21 years old. It's fully covered. And then if you're 21 or above, I got this receive full subsidy, but just now Professor Jenkins said that after 2002 to 2022, you get a co-payment subsidy. And then also, it's available for women for type 1D actively planning in pregnancy, pregnant, or immediately post-pregnancy. So let's also look at reimbursement situations in Asia. In Taiwan, it's also a funding model by the government. It's universal health coverage by the National Health Insurance Administration. And then since November 2023, pregnant patients with type 2D or GDM undergoing insulin rejections, and also type 1 diabetes, they adopt the treatments of CGM devices on 1 month interval are reimbursed. As for South Korea, I actually got this data from Elaine. So Korean National Health Insurance Service, CGM reimbursement is in January 2019 and centers on patient training in August 2022. And also people with type 1 and type 1 diabetes and GDM get reimbursed. There's a co-payment, a government subsidy for patients less than 21 years old. It's around 90% of reimbursement. And for patients above 21 years, it's 70%. For GDM, it's any age, it's at 70%. And then for Singapore, we also heard it earlier. So around 80% of the CGM and components for the type 1 diabetes is reimbursed. They started the reimbursement around May 2024. It's also for type 1 diabetes above 7.5 or disabling hypoglycemia. For Japan, they got this new code that I searched. They made it really easy. So it's regardless of the type of diabetes, as long as they're on insulin, under the code, reimbursement code of C150, it gets reimbursed after April 2022. So in Asia, there's only Malaysia and Hong Kong left that is not having CGMs reimbursed. So hopefully we're going on in the road, and hopefully we will get CGM reimbursed soon. Thank you.
Thank you so much. This has been incredibly insightful. In the interest of time, what we're going to do is going to go straight to the work that needs to be done, which is why we don't have, how are we going to get CGM reimbursement in Hong Kong? What Dr. Jenkins has said, what Dr. Juliana has said, yes, it's around the region, it's around the world. We need to actually be the advocates. In this room, you're the advocates, okay? So we want to empower you. So what we're going to do is we're going to break you up into different rooms, and we're going to change the format a little bit. We have breakout rooms outside. So what we're going to do is we're going to have question 1, which is how would you benefit, who would benefit most, and who should have priority to get equitable access to CGMs in Hong Kong? Of course, think about type 1 diabetes. Of course, think about type 2 diabetes. Who should get it? The elderly, the pregnant, all right? And orange and yellow and green. Orange, you all have colors. Orange, yellow, and green. I'm blue. So orange, yellow, and green, you are going to cover this question only, okay? We're going to have a quick debrief in another room. We need your ideas. There will be observers in your room as well. Please come up with solutions. We need solutions, right? Recommendations, and what you think and why practically we need your voice. So you will follow now, and everybody else, you'll stay in this room and we'll work on discussion point 2, okay, in this room. So in this room, it's blue and purple. Blue and purple will stay here, okay? So we're going to work on question 2, okay? What could the options be for different CGM models? I'm going to let Professor Ronald lead this, and he will help. Okay.
I think it's an open discussion for all of us. I think we've all heard really inspiring sharing. And I think what's pretty important is that actually Dr. Lam alluded to thinking ahead about funding models because of how the government is thinking about co-pays and various things. So I think obviously we also heard from our survey what people with lived experience with diabetes in Hong Kong wish to have. So how do we balance or think about the different options for funding CGM? So we want to hear what people in this room thinks, because we all wear different hats, represent different sectors, but we need to come together to have some kind of consensus, because to move ahead on this road, we need to sort of gather evidence, gather opinions, and try to gather that and try to present that. So maybe can I ask? So I guess you saw that question. So of course, what we ideally want is for the government to pay for 100%. I think that's obviously what we're going to shoot for. But what are the alternatives in terms of like thinking about co-pays? Because I think Dr. Lam also alluded to means testing. So not everyone, for example, is it a by proportion in terms of subsidy across the board? And then if so, what do we base these on? So
I think shall we recap the cost of using CGM in Hong Kong now? Because in the previous slide, it showed it costs around 2,000 or 3,000 per month. But now the CGM, the cost of CGM is a little bit cheaper. I think it costs around 1,000 per month, 1,200 per month.
So 600 for 2 weeks or 10 days would translate. Or we got some
cheaper model now, which costs around 800 to 900 per month. So this is so we yeah, even cheaper.
Sorry, I just say I pay 500 per unit for
Yes,
my son.
yes.
If I buy 12 of them.
Yeah.
Which of course, I think they last a couple of weeks.
To 15 days nowadays we got
500 is the cheapest I found. There's 7. Yes, G7.
G7, or even we got the of course we got the Libre 2 Plus, and also the new brand called iCan, but of course a lot of model right now. So I think the monthly cost, so we bear in mind around 1,000 around per month.
So we probably have to benchmark against the most commonly used and accepted brands. I think the newer brands, newer manufacturers, which are not as well accepted or not as familiar by healthcare providers, we need to keep those costs in mind, but we probably need to make our cost calculation based on the most accepted ones, I would imagine. So that's just something to bear in mind.
But I think with the government really needs to sit down with someone like Dexcom and do this private discussion about what they'll sell them to for. So the Dexcom will still make a profit and the people here get it for free. I just think they need to start direct discussions with Dexcom themselves or another type of CGM.
So maybe I'll ask one of the experts.
I think when we discuss about the options, we need to know the number of patients who are likely who need the CGM. And that relates to the first question as to what we think, who would benefit most from using the CGM. Because the number makes a huge difference. If type 2 can use it, then I think the government won't say yes, because there are tons of type 2 in the adult population. So I personally think support the use of CGM in type 1 under 21 and in women who are preparing for pregnancy or during pregnancy. because the number would be low and the benefit would be very high.
Yes.
Not saying that type 2 has no complications, but I don't have a lot of experience with them. But for some elderlies, even if you give them a CGM, they don't want to use it. They just want to live a free life, don't want to know about the sugar level and what they can eat and what they can't. So, of course, young type 1 who are over 21, they also need that. But I think we need to start small, get it started, and then we can move forward.
Thank you. I have a question about the discussion 2 topic. So when we talk about funding models, we are specifically talking about government funding. Is that right? Or public funds?
Mainly government funding. I mean, we do have representatives from insurance companies actually in the audience today, but we are mainly thinking about trying to get public funding first, because that would benefit everyone.
Right, I see. I see. Just to recap, I think it's about $2,000 a month, approximately. How many dollars per person? Less than that. Because Manoj says
It's
20,000.
1,000 now.
Okay, got it.
I know Professor Jenkins is online. I mean, please feel free to chip in. I apologize because of time. Ideally, initially, we were supposed to discuss both questions, which would address that important point of thinking about the cost. But I think because of slightly overrunning in terms of presentation, we just given. But I think to that point, I think probably anyone in the room does not agree that children should be the priority, type 1 diabetes should be the priority. And I think the very important point that Professor Jenkins made, also that in Australia, I mean, to have someone having CGM and then taken away when they're 21, that's terrible. And I think then anyone who's already using it because they have type 1 should continue to have it. So that would mean sort of the target population we want to at least advocate for initially is everyone with type 1, everyone who is planning or having a pregnancy, and then hopefully, if that is secure, then moving on to older young adults who have diabetes of any form, and then hopefully eventually everyone. I guess we sort of jumped the ship, but kind of I assume anyone disagree that's sort of the framework we should think about. If that's the case, then coming back to discussion 2, then the options for different funding models would, first we think about public funding in terms of what should we ask the government. So Dr. Lam was actually in the corridor, he was actually very open. He said he's heard everything. He's asked us to put together a 100-word pitch to the Legislative Council to actually say what is the question that we want to ask the government. So we're going to have to think how we want to phrase that very, very carefully. But the evidence, he put it in, the word he actually used was 質詢. So the term he used was, what are we going to interrogate and put our government to be answerable for? So being able to very strongly support why we think this population would benefit. And I think based on everything we've heard, children and everyone with type 1 diabetes would be the obvious population we want to support first.
The clinical evidence is strongest.
It's so strong,
for
yes.
Type 1. So in terms of options, I think it's either fully paid by the government or a kind of subsidy. It looks to me that Dr. David Lam is very supportive of means testing, but I think it's quite difficult to implement, and it will take a long time for the government eventually to be able to do that.
Yeah.
And if we concentrate on only type 1 in children to start with, actually the number is small.
Yeah.
And in that case, I think we should strike for full payment by the government. It won't cost them a lot.
Yeah. Sorry? Yeah, exactly. Yes. Yeah. Yes, I mean, as I said at the beginning, I was so embarrassed to find when I was working on this type 1D index to see, actually UK, the healthy years lost due to diabetes is the lowest, it's 15. Ours is 31, it's double. Australia is in between. Australia, I think, is 19. Professor Jenkins, you wanted to say something?
And Japan has the lowest healthy years life lost. Yes, look, that's fantastic that you've got the opportunity with 100 words. I think I'd encourage you to consider using the model that worked in Australia, going for the low numbers of children and young adults with type 1 diabetes. And also as well, it's not appropriate to means test them, and that does away with the costs. So that opportunity to craft your 100 words sounds fantastic. And the body of evidence is certainly there for type 1. And all of those other countries is also in your favour because affluent governments don't like being left behind.
Yes. Thank you. And thank you so much. I mean, Professor Jenkins has really been very generous in sharing a lot of insights with us, even before the Jockey Club project started over the years. And thank you so much. And also introducing insulin pumps to me. I sat in her clinic. Okay. Other thoughts?
One thought about that 100-word inquiry, right, at LegCo. The message is if the Hong Kong government is very keen on growing the population again or encouraging people to have children or make Hong Kong a great place to live, okay, so we have to provide more comprehensive support for young families, and obviously that include people who may have children who are affected by T1D, and then that can be anybody. So that's a message we can send to the relevant people.
Yeah, I think that's a good point. The only thing is, with that point, do we want to put the emphasis on having children, which is actually now talk about pregnancy, which is the second step,
yes.
or children with diabetes, which is the first step?
Family-friendly policies.
Okay.
People
so more
feel,
general.
Yeah, quite general. And T1D is very small population, and it would be easy to convince the government, I hope, right? Because I think Dr. Lam was very conscious, right? He was like, if we subsidize this type of disease, would there be some other type of disease who require support? And he's very apprehensive of any potential abuse. Yeah. So perhaps when we go out with a message, eventually, I understand we would want to go for 100% subsidies or zero copay, but at the same time we can leave it open with the messaging, right? Yeah. And they can come back with mean testing, but we can say we would like to see the government stepping up with more support for government for families with T1D conditions.
Thank you. I think that question that we put in the survey about percentage pay. Yeah. It was painful drafting that because, of course, we want to fight for 100%, but it was interesting to see if we went down to 50 or even 75% copay, what that meant. And of course, looking at and listening to the other countries, I kind of think 10% would be the bottom line because, I mean, 90% cover by government and 10% copay if they really want some kind of, because most places are able to afford that, or 100%.
I think we just want to get food in the door, right? Because we have a budget now, but we can say with overwhelming evidence from so many countries, and they actually have policies in place to assist the families. And what was that line called? The threshold. Yeah. Dr. IC, right? That line shows that is cost effective. Right, and how can we not at least try to implement a pilot program, right, to get it started, and then we can get the foot in the door, get some subsidies first, and then we can eventually expand, and we can look for that equilibrium.
In terms of numbers, I mean, the T1D index estimate about 4,000 people or 5,000 people with type 1 diabetes in Hong Kong, but actually a lot of those probably are adults. I think in our analysis of HA database, we had an estimate of around 2,000 to 2,500 people in HA with type 1 diabetes. Again, that includes adults. So we're actually just advocating for children, people newly diagnosed with type 1 diabetes. The number is actually pretty small.
Right.
I would imagine probably more in the region of 500.
Yes.
500 people.
500.
Okay.
Yeah, so that's the sort of numbers we need to be thinking about first. And that's not too much.
Mike.
I mean, what would be the definition of newly diagnosed?
Presenting, new cases presenting. But if we are covering everyone with type 1 diabetes, children and then onwards, then that should cover all the children. That should be included already. I mean, the number of new cases per year is actually quite low, regardless of age.
It's less than 100.
Yeah.
New cases is less than 100 a year. The total number of cases managed under HA, I think, is 5,000 is a rough estimate. And if the government really approves such option, actually the price of the CGM will go down, just like all other drugs being used by HA. Yeah, they will work with the pharmaceutical companies to strike for a better price.
We do have a colleague from one of the CGM manufacturers here, so he's very kindly he's participating. But I think they understand very much, and exactly Singapore has been able to do that and actually work with them to get better access at a lower price, at a confidential price, but to make sure more people can benefit. So indeed, I think this is why it has to be a multi-way discussion.
Just wait a few more minutes, but I just want to let you know, in this group, when we're sharing feedback of ideas, who'd like to do it? Okay. Well, what ideas? Well, whatever is discussed here. Okay. And someone come up with some bullet points and share with the whole group. Bullet points. Yeah. Don't worry, Craig's been taking notes too. The share notes with you. Yeah. And what I want to say as well is what Dr. Jenkins has said, and what has been presented by Professor Carr and Professor Gardner. When I was walking out, David had said, actually this is really good because you guys are the actual advocates. We need your help. If you want this going, we'll just get you the right government department, but make the case. Work together with the parents and the stakeholders, the patients. They're really the ones we're gonna have to do. Just give us the support we need. So who should benefit, all right, is one thing, and then how do we do it is the solution we need to give them. Okay, so I'll leave you to think of that. So we're on the right track.
I have a personal experience to share, which is actually very sad. 30 years ago, one of my patients immigrated to UK. And when he arrived at UK, the doctors there marveled at the level of care he was receiving when he was in Hong Kong. He was already on multiple daily injections at that time. Now he's grown up, he married, but he has free CGM. But my patients now in Hong Kong couldn't have free CGM. So at one point we were walking very fast, but now we are lagging behind quite a lot.
Yes, I feel that every day as well. It's just saddened how we were at the forefront of clinical care medicine in many ways, but on this aspect, we really are not doing justice. I was president of Diabetes Hong Kong almost 10 years ago. And at that time, we were trying to just get access to SMBG reimbursement. That's how I first learned about NDSS, because they were providing reimbursement for SMBG instant syringes, and we don't even have that in Hong Kong. And we tried through Diabetes Hong Kong to get cheaper glucometers and access, but I mean, as healthcare professionals, we are ashamed because of Hong Kong being so-called high developed economy, and we don't even provide that.
Walk anyway in 30 years.
Yeah, we've regressed. in comparison. But having said that, the diabetes care we provide in general is actually one of the best in the world. So there's been a recent analysis to show decline in mortality due to diabetes. Of course, that's mostly type 2 diabetes. And out of 17 high income areas over the last 15 years, Hong Kong has shown the highest drop in mortality rate due to diabetes. So in terms of all the other things, we're doing the right things. But I think for people with type 1 diabetes, we are really not doing what we can.
Yeah, I have one question about the specific CGM funding model that we want to talk about. I just want to envision this. When this happens, right, do we like go to the HKMA or go to the hospital and pick up a CGM, or we buy it off the shelf and get it reimbursed somehow? How would that work specifically?
So I guess there's several things. One is the logistics of the reimbursement.
Yeah.
One is how to get the qualification. I think Dr. Lam alluded to it in the corridor. He sort of said a lot of these will now be done through, because I highlighted that this is not going to be done in primary care. Primary care don't look after people with type 1 diabetes. We do in hospitals. So what he mentioned was a lot of the time, for example, if their first presentation is to hospital, either in clinic or admission, that will trigger the coding for potential reimbursement. Like the clinician will say, this is someone who would benefit and would qualify. Then somehow, then the system has to activate that. And then perhaps they would have to purchase it and get reimbursement. Or quite often like medication, if the hospital has that medication, they would get it from the pharmacy and that would just be waived. They just don't pay. So if it's yeah, it's complicated, and a lot of people can't afford to give the money first. So if it's direct transfer, but only if the hospital is prepared to stock. And I don't know whether all hospitals have like rehab shop to actually provide that, but that would be the easiest model. But I think that's the next step. I think, yeah. I think it's yeah. Yeah. So we need to be clear. So we need to be clear when presenting kind of how we think it should be funded. What is the ideal scenario, and what are the other options?
How about corporate funding?
Sorry?
Is there any way we get help from corporates? Like Jockey Club did this, but then...
Sure, but corporates is not sustainable. So if you ask a corporate, so Jockey Club has been very generous, but they made it very clear they are piloting this to give us data to then pitch to the government. They want the government or someone to take it. They were quite clear about that. And corporates, if it's a charity, if it's corporate responsibility, they want to sponsor something, they're not going to do it forever. And they won't do it for everyone. So corporates, whilst it's important, and maybe they can support other aspects of this. They can support pilot programs to expand this to older population, for example, or specific disadvantaged groups. But corporates won't be the long-term solution. I think that's. Do we have enough ammunition?
I will have to.
Okay.
Yeah.
Thank you. So thank you, everyone. Thank you for all your input.
We'll start in a few minutes, and with everybody coming in. And Dr. Jenkins, we're very grateful that you're with us, listening to this part.
No, that's fine. I think you've got stacks of ammunition. Go for it.
We're going to be tapping into you quite a lot to get some. I mean, that data is fantastic, and it's exactly aligned to what we.
Alicia, I know it's getting late in Australia.
Fine, no, it's fine.
Hang on. Okay, thank you so much. Sorry about that. Thank you.
No, not at all. I'm delighted to hear and to see the progress. It's fantastic.
Thank you.
Okay, so we're going to start having your feedback, all right, as stakeholders, your feedback. On the first point, which was the blue group, we have someone who's going to speak on their behalf. You think you're ready? All right. Or you okay with that? Yeah, okay, great. Would you like to stand or sit? Okay, great. Thank you so much. And if there's anybody who wants to join him as well? Yeah, we have a question too. Sorry, you stay. Sorry, my mistake. I'll come back later. Yeah, we'll come back later. It's question group 1, discussion 1. Can we have yellow group please to come out? Yellow? Thanks. Okay, come on over. Thanks. A breakout group, yeah, for yellow, yeah. Yeah, yellow, yeah. Here we go. Thanks.
Yeah,
You want to use it English or Cantonese? Doesn't matter.
English. My Cantonese is Mama.
Mandarin is no, we can't do Mandarin.
English, okay. Okay, sorry.
Okay, no problem. Thank you.
Yeah. Our opinion is we should divide into the different groups with a different priority. Yeah. The first priority should be type 1. Yeah. The second priority is GDM. GDM. Yeah. Yeah. The first priority is TD. Yeah. So our opinion is divided into the 3 groups. Yeah, with a different priority. The first priority is type 1D. The second priority is GDM. The third priority is TDM with insulin treatment. So that's our decision. Yeah.
Okay. Is there anything else your members of the group like to add to that? Any points? So priorities TD1, GDM, and then type 2, right?
Type 2 with
insulin
treatment.
With insulin treatment, yeah. No? Okay, great. Thank you very much. Thank you.
Thank you.
Thank you so much. All right. Very pragmatic. Green, please. Green, Loksik. Yeah, there we go. There we go.
I think our discussion is any patient who have diabetes require insulin. And then for the age group, we suggest to government to subsidize for those pediatric patients and also those patients who are full-time student but age less than 25. Just match right now the current government policy. Yeah. All the test player, the deductible test, they actually use the cutoff of 25 and full-time student. Yeah. So it's our discussion.
That's very pragmatic. Thank you. Continue what we're doing already. Yes. Oh, sorry, you have a point? Yeah. Yeah.
Well, during our discussion, we were talking about how many people actually have T1D less than 25 years old, and might be 400, 500, 2,000.
Do we have the number?
25? So it's nothing, 400, which is like compared to the government putting on the medical 1,000幾百億嘅時候, we are talking about 0.005%, right? So I think we should get this number, put it on the place, and then what we are talking about in the future complication, all this money, just put it on the...
So you're thinking salami tactics, right? You start one slice, you get that, and then you make such a good case. Economically, it makes so much sense. You have to get the next slice for, the next group, right? Maybe you're right. Maybe you're right. Thank you. Excellent. Right, orange group. Yeah, orange. Oh, different color garbage. Yeah, he's got a yellow.
Hi, thank you. So for our discussion, the first priority is, of course, children with T1D. We think that the government should, or whoever, should fully subsidize it. So it should be totally free for them, because it would be much easier for them to manage their diabetes, especially for their parents to help them. Because when you are at a younger age, it's very difficult for your self-management, so you greatly rely on parents. So that's why we think it's totally free. Then the second priority should also be pregnant women with diabetes. Again, it's totally free with similar reasons. I think one of the reasons is that it's a short-term issue. It might not change into a long-term subsidy, because after the pregnancy, it could end. Then the third, it's young adults with type 1 diabetic. We think the subsidy should, we could kind of accept that it's not fully subsidized, but at least we hope that the price of using CGM could be lowered or could be subsidized until that it's similar when we are using finger pricking, the cost of finger pricking. Because by then most of us would willingly switch to the use of CGM, which have greater diabetic management benefits. But while here, we would also like to add one other group, which are newly diagnosed type 1 adults like me. So because then we are no longer children, but then during the process of learning management of diabetic, I think CGM are very important. So maybe for other young adults like me who are also newly diagnosed, they could have several years of CGM fully subsidized, then switch back to, co-pay methods that it's pressed down until like finger pricking price. Then lastly, then will be type 2D with insulin treatment and other type 2D patients. And that's for our group. Thank you.
Oh, thank you. Thanks. Right. Anybody else want to add anything from that group? No? Okay. Purple. Purple. Here you go.
All right. We're talking about 50%, which is the minimum. But we are thinking, instead of the Salome slide, we're thinking about to ask for 70% so that the government will, okay, it's like bargaining 50. 50% is the bottom line for us. And we actually go into detail as well. We talk about the community pharmacies, because maybe we can get these CGM from the community pharmacies, because the government is actually promoting it. And we thank you to Dr. Benjamin Aouyang, and he's very good because he's from HA. He gave us some tips that actually CGM voucher is one of the things. And then we put in HbA1c criteria. In case for the person who is not reaching certain levels, say for example, still keeping the HbA1c as 10 for 1 year, after giving out the CGM, we will stop giving him. So this is something like, it's a penalty, because so that we can reassign the resources to other needy patients. So that is the thing. Did I miss anything? Okay, improvement of HbA1c is one of the encouraging factor as well. And then we're talking about insurance. If we use CGM, we may be able to speak with the insurance company to allow us to purchase insurance from them. VHS, I mean, diabetes people cannot even get VHS from the insurance company. If we have all these data available and present it to the government as well as the insurance company, we may have better bargaining power. That's all from us.
Fantastic. Thank you. I like that. Right. So we're going on to the second question, and from the blue group that Professor Ronald has facilitated. You ready? Thanks.
Thank you. Yeah, in our group, I think the funding model is quite straightforward, right? The government will have a role. And the message is, if the government has a role, right, does the government have a role in promoting Hong Kong as a good place to live, a place to raise a family, right? If the answer is yes, I think there is a role or / a duty for the government to step in and protect the family or help the family with T1D to raise the children in a very safe manner. I think we will be also open-minded about the actual funding or co-pay level, right? Because the strategy is get the foot in the door, right? Once you get the foot in the door, whether it's 10%, 20%, at least you have a start. And another strategy is to frame it as a pilot program, right? We can say if there are overwhelming evidence from Korea, Japan, or many other countries, right? That is, they are below that line of the threshold of effectiveness, right? And how can Hong Kong be not at least consider starting with a pilot program? Then we get a foot in the door and then gradually expand the program. Is that it? Any Dr. Mai, any supplement?
I guess that covers most of it. I think we wish to have 100% subsidy if possible. I mean, that's what everyone in this room wants. But I think we're prepared to go to subsidy if necessary, but modest subsidy, not a large subsidy as we've heard from the opinion survey. But I think the important thing is actually to start with the small group. Type 1 diabetes seems to the most deserving in terms of the evidence, and we need to support that first. But hopefully, with that being successful, then the opportunity to expand to other groups, as we've heard from other speakers. But I think that's the important message.
Thank you. Thank you, Dr. Ma.
Thank you very much for that. Wow, this is really, really productive. That breakout group really gave a lot of ideas. I saw so much discussion among the group. Is there anything anybody wants to say, any idea you want to bring up now while we still have Professor Jenkins on the line? She's been very kind. It's 3 hours ahead for her, but she's still with us. Is there anything anybody want to say? Oh, Vina? Okay, great.
Alicia, hi, this is Vina here again. I have a question. I know that you actually went to the Congress to ask for CGM supplies. How did you do that? And how shall we do? Thank you.
And I'm happy for people to share the slides. So again, it was the United Front. So we had people living with diabetes, their family. We had the diabetes associations, so the equivalent of YDA. We had healthcare professionals make appointments to meet the policymakers in government, and we also had the data showing the evidence that your Hong Kong Jockey Club data is very powerful, but also showing that from other countries, and that health economic data. And you could see that when we pointed out the low number of people, the relatively low cost, then that you're not asking for all people with diabetes, the large numbers of type 2 diabetes, then that's and that it's a social justice type thing. I think between what you've got internationally plus the local data that you've got, and you've got an even lower rate of type 1 diabetes in Australia, you've got an affluent country, and I think it's I think you're very well placed with where you're at now to get that a representative group. What government, at least in Australia, likes to hear is a united voice asking for something that's perfectly reasonable, and I think you're incredibly well placed. You will know how to approach the government, but I think many of the people and the organisations you need are here today, and you will know the others. So I think get your 100 words and assemble your data and have a reasonable ask, and I'm very hopeful that you'll get a positive response. And I'm happy to help however I can and connect you with some of the other people who are involved in that from Australia, as Partha Carr also offered.
Well, with those really choice words, we're very grateful to hear that. Thank you for all your help. We're going to close now with a few words from our chairperson emeritus, who's founded this whole thing. Please welcome Joanna.
Thank you. Wow. Wow, is your brain spinning? My brain is spinning, my notebook is full of notes. I know we're tight for time, but I just want to say a few words. First of all, I want to thank all of you for being here. We have had the most incredible speakers today. I mean, global speakers, literally global. I won't go through all their names again, you know who they are, but how fortunate are we in Hong Kong to have the support and the generosity of all of these incredible people to help us. We're so grateful. And also to the YDA team. Well done, team. Well done. Wow. Organising all of this at short notice. I want to thank YDA and also our medical advisors, many of whom are here today, and also to the CU team. Really, this collaboration that we have, this partnership we have with CU, thank you so much for everything. We're truly, truly grateful. And of course, our members. Without you, we are nothing. So thank you to our Our kids, our parents, everyone who's a member of YDA, thank you so much for everything that you're doing. Thank you particularly for being here today, for speaking up, for making your voice heard. Right, just a few key takeaways. Just wanted to remind you of a few things so that when you leave today, these things are sort of uppermost in your mind. These are the things that struck me. You may have been struck by other things. And I'd like us to continue this conversation, keep thinking about this and act upon it. So Dr. Lam reminded us that the government is reviewing all of healthcare at the moment, right? Diabetes is one disease, one condition. There are multiple conditions. He was talking about the government's means testing initiatives and different subsidy levels. That's probably where we are going to be looking. It's looking at the different subsidy levels and where we can position ourselves when we actually advocate for people with diabetes. Dr. Elaine Child showed us, the HbA1c reduction by 0.5 to 1% using CGMs. The data from our YDA survey, 90% plus people who completed the survey said they had a positive experience, and also that the biggest challenge is cost. The biggest challenge for all of us is cost. Professor Carr reminded us 99.9% of the time, diabetes patients are on their own. We're on our own, right? Whether you're a patient, a parent, and we need self-management tools, and we need to have access to those tools. He also mentioned that to go below 7.5 HbA1c, we need CGMs. To go below that, even more, we need closed loops. That's another forum. We'll start with the CGMs. He also reminded us that you cannot change population numbers without tech. And I think that's a really important message, because that's the kind of message we need to be giving to our government. Dr. Gardner, interesting facts from our competitors in Singapore, particularly in raising patient voices. She really highlighted its patient voices, and it's the importance of peer support communities that actually made that happen there. And Professor Jenkins, are you still here? Yes, thank you so much for all of your support to us. If you can only afford one device, get a CGM. That really stood out for me. The hybrid subsidy model from Australia is an incredibly useful base for us to look at when we start pitching our own possible model. The political lobbying, the economic framing, and the way that in Australia they started with children is another area that we can also learn from and potentially follow. And of course, Dr. Juliana Lui, the cost effectiveness of CGMs, the health economics analysis, I have to say my brain felt like it was going to explode, but I get it, because that's the data that the government is going to want to see, right? And also what was interesting is the willingness to pay statistics by stakeholders. And also I was sad to see that only Hong Kong and Malaysia in Asia, we don't get reimbursed, right? That's terrible, it's terrible. Okay, so next steps, practical steps. Thanks to Chinese University, they are working on this economic modeling, continuing to do that, continuing to do really interesting and important research into the data, with the data that is being generated from the CGM program that we're currently working on, which is going to be very, very important for our advocacy. And YDA will continue to lobby. What we will do is we will consolidate everything that happened today, the information, the people, the ideas, the vibe. Can I say the vibe? We don't want to lose this, right? We don't want to lose this passion that we have for our cause that we generated today. So we'll definitely build upon what's happened today. We must all raise our voices. If this is going to happen, it has got to come from you first, patients first, okay? Dare I say kids first, okay? Patients first, parents, all of the people with diabetes, with type 1 diabetes, all diabetes, and then YDA, what we are aiming to do is pull that all together and work with our generous partners, our doctors, our medical professors, etc., work with them to actually build a case. And we did get some useful tips from Dr. Lam, actually, in how we can frame this. We're all stakeholders in this, and we can do it if we all work together. So I'll just end by reminding you all why we're here, because no child should be held back because of diabetes. Thank you.
Thank you so much, Joanna, for this. Look, I'm coming to this and I'm feeling very moved. I'm seeing the expertise. I'm listening to what you're all saying. I'm listening to even the observation of those from the manufacturers of the CGMs are with us. I will just say one thing. It only starts with one drop, right? One drop, then another drop, then another drop of keep persisting and persevering. And with that, I think we have enough of a group already to start this turnaround that we have to see. I will be predicting, give it 1 year, 1.5 years, we'll be back in this room, in maybe a bigger room, to say thank you to everybody who's been here on this journey, because my vision is that all the advocacy that's going to be coming from this point on, this drop by drop by drop, is going to make a very big difference. And we're going to put our lives in Hong Kong back on track. We were pretty amazing. We still are pretty amazing, but let's get ourselves back on track to where we should be so we'd shoot for the stars. Thank you very much. It's been a wonderful Saturday. It's been really grateful. Thank you very much. My name is... Thank you.